Today is going to be a marathon of a day, but a fun topic, I think, and one that's very, very practical because the stuff that you learn today and next week are concepts that you absolutely can, should, and will apply to your normal everyday practice of medicine outside of critical care even. But this will make you a better paramedic just overall for airway management. When you look at the NCCP model, airway, respiratory, and ventilation is so important, it's its own category. So they don't lump it into medical, they don't lump it into trauma. It's its own separate category. That's how important it is. It's a gigantic topic, my friends. So like Dora, we're gonna need a map. And so just very quickly, today, week number 3 is part 1 of 4. 4 parts to airway, respiratory, ventilation. That's a month of ARV, okay? So this week, we're gonna cram all this stuff in today, this week. We're gonna talk about the physiology of breathing, the hardware and tools needed for airway management. Again, all stuff that you'll definitely be able to use on your normal everyday practice of paramedicine. The process of direct laryngoscopy and intubation, which you're all thinking, I'm sure, well, I'm already a paramedic, I know how to do that. I guarantee you, you do not know how to do that. Not appropriately, step by step. We do it. When I get the opportunity to teach airway in paramedic school, they got pretty much of it, but if not, if you never took from me before, I will guarantee you we can fill 2 hours with just the direct laryngoscopy process. And then number 4, the pharmacology of intubation. So lots to jump into today. Now next week, we're going to talk about managing complications of endotracheal intubation. We're going to talk about surgical airways when everything goes wrong. We're going to talk about managing patients after intubation. And then we're going to have an afternoon skills lab. And that will be very fun and very hands-on. We're going to do a little bit of a live demo after lunch today, which is also really cool. After we go through the 7 Ps of intubation, this afternoon after lunch, we will go through those 7 Ps again as a matter of review. I guarantee you that's 7 test questions, easy right there, right? And the cool thing is, after you now understand what the 7 Ps are, you'll watch instructors Stewart and Bauer to go through it in real time and demonstrate how it should be done. So it's going to be really, really cool. Then on week 5, which is part 3 of 4, you'll go through the fundamentals of respiratory physiology. You'll prep for week 7 and 8 actually, where you're going to spend 2 weeks on just the ventilator, like how to fly a T1. And that's going to be very hands-on as well. Dude, I tell you, there's so much that the Hamilton T1 can do, it blows your mind. So you will never understand 7 and 8 until you go through week 5, talking about the fundamentals of respiratory physiology, because that's, you know, we teach you knobology in orientation process and just kind of how to basically what the knobs are on the T1, but for this, you're going to learn the whys behind every knob on a T1. You're going to do invasive and non-invasive, and then finally on week 4, you're going to put it all together. We're going to get classroom, you're going to get sim lab. You will see that study hall is scheduled into that week. I highly advise you take advantage of the directed study hall. That's going to be key. You'll do a practical exam prep with airway management. You'll put it all together in the sim lab from start to finish. You will start an airway and finish an airway. You'll have complications in between, just like in the simulator at NASA, where they throw in alarms and stuff. You got to do the same thing. You'll manage those alarms, and then, of course, your actual exam will be July 25, which will be here sooner than you know it. So, but don't worry. Again, we will set you up for success. We'll give you all the tools necessary to succeed. If you take advantage of them, you'll fly through this, and it's awesome. And frankly, this is why, once you become a critical care paramedic, the road crews will look to you for help on bad calls. This is why we call for a BC on, priority 2. Dispatch always says, Do you need a BC? Because most of our BCs are critical care certified. And they have the paralytics, they've got the extra training and tools, and they will bail the crews out if needed. Okay, so you'll be a force multiplier on that end. I'm sure many of you in here will become BCs, leaders, and you'll be wanting to be that resource for the road. So definitely a ton of stuff. So let's just jump right in, shall we? General anatomy. You've got to understand when it comes to just breathing, the general anatomy. On your left of your screen is an actual cadaveric specimen of a brain and central nervous system of where we breathe. The pons, this circular thing, and the medulla oblongata, the part of your brainstem, is then kind of depicted here in this cartoon drawing, which might be easier to see. But the pons and medulla oblongata are central to our ability to breathe and our respiratory centers, okay? Professor forgot the letter A there. It should be the medulla oblongata, if you've ever seen Waterboy. Fabulous, classic film. Should be in the Library of Congress. The medulla oblongata and the pons are where the DRG, VRG, pneumotaxic center, and apneustic centers reside. Let's take a look at the medulla oblongata first. So the medulla oblongata is where your dorsal respiratory group, and what does dorsal mean? Back, so you remember, I always remember that, the dorsal fin of a shark, right? The jaws coming along. So the dorsal respiratory group, which is represented here in this dark blue kind of oval, and the ventral, or then opposite, which is front, the ventral respiratory group, which is this larger oval-shaped light color blue, together make up the medullary respiratory center. The dorsal respiratory group is what stimulates the diaphragm for rhythmic breathing. This is the reason why you don't have to remember to breathe when you fall asleep. When you fall asleep, the DRG kind of takes over and makes sure that you keep breathing so you don't die when you're sleeping. It is damaged to this part of the midbrain, which makes people ventilator dependent. If that does happen, they'll never be able to sleep or they'll stop breathing and die. So the DRG is what's responsible for that. The VRG, or ventral respiratory group, is your forced inspiration and expiration. So you're sitting here, you're not thinking about breathing because you're in rapt attention to this amazing lecture. The DRG is breathing for you. But then if I say, okay, everyone take a deep breath, now force out, okay, your VRG takes over. You can override the DRG and make yourself breathe or not, okay? The pons, however, contains the pons respiratory centers, which has the pneumotaxic center and the apneustic center. The pneumotaxic center inhibits the AC, the apneustic center, and the DRG, and prevents overinflation, basically, so you don't take such a deep breath that you cause barrel trauma to yourself. It kind of stops you. And then the apneustic center stimulates the dorsal respiratory group, which can prolong inspiration if you need to. Like if you want to take a sigh or take a deep breath, it can allow you to do that or prolong inspiration. The pneumotaxic center is this group of neurons in the pons, again, that allows for exhalation, prevents overinflation. You can see that the pons, the midbrain, acting as the central controller for inputs and outputs, are always receiving information from the body, from chemoreceptors and other receptors. And then your respiratory muscles, respiration, the diaphragm, intercostals are all respiratory muscles that help with the overall respiratory control. Now, what is it that drives your respirations mostly? Well, a huge portion of that is going to be your acid-base balance, right? As you sit here, it's not, everyone thinks about the kidneys as the primary acid-base controllers of your body, and it's vital to that. But the second to second, minute by minute changes really is in your respirations. You're not even aware of it. But when you're sitting at a desk versus all of a sudden you get up, tones drop, you run out to the bay, jump in the truck, put your turnout gear on or whatever you need to do and start going, you're not even aware that your respiratory rate is probably increasing a little bit to offset the increasing acidosis that's subtly occurring as you run out to the bay. But that's because your respiratory centers are taking care of that. It responds very much by CO2 and hydrogen ions. And so your brainstem is sensing that. The chemoreceptors, which are the chemical chemoreceptors, are sensing changes in bicarb, CO2 rather, and hydrogen, and will control speed you up or slow you down, depending on what. Now, the carotid bodies are your chemoreceptors versus the carotid sinus, which is your baroreceptor. Okay? So when someone's in SVT and you're trying to do a carotid massage, you're trying to slow them down, not by stimulating the carotid body, which is a chemoreceptor, but the carotid sinus as a baroreceptor. They're driven by the oxygenation. That's your body's internal pulse oximeter. They can detect those as well and help balance both chemical and waste products, CO2 and hydrogen, and oxygenation to tell your body how fast or how slow to breathe. Make sense? So we kind of put it all together. This graph we're going to spend a little bit of time on because, oh my goodness, it is rich fodder for tests. You absolutely have to know this graph. Tidal volume, inspiratory reserve volume, and expiratory reserve volume are represented on this particular slide that we're going to talk about. What is tidal volume? Well, that's easy. That you know. Tidal volume is just the regular amount of air inhaled and exhaled in a normal breath. That's your tidal volume. What's your normal tidal volume? About, average. 400 for everyone in here is dudes, so 400, 450 maybe. Females, 350 to 400-ish. So a safe average tidal volume is about 375, 400-ish. Okay, so just for sake of math, 400, fine. Somewhere around there. Also, obviously, depending with your 6'3" or 4'9", that's also going to affect it. But in general, that's about how much a normal breath is, a normal tidal volume. So the inspiratory reserve, okay, that's represented here by that in and out. This middle bar right here, tidal volume. The IRV, or inspiratory reserve volume, is the amount of air that can be inhaled after a normal tidal volume breath. So inhalation, rather. So if you're just breathing here, but at the top of that, I say take a deep breath. Even more than that, that's your IRV, your inspiratory reserve volume, illustrated by the top of that graph, that big top graph there, top bar. The ERV, or expiratory reserve volume, is the amount of air that can be exhaled after a normal tidal volume exhalation. So again, you're just sitting here breathing in and out, and as soon as you just are done breathing out and about to take another breath, I say, okay, now blow all of it out. That's your expiratory reserve volume, represented from here to there. The residual volume is just exactly what it sounds. It's the residual, how much volume is left in your lungs after you forcefully exhale, maximal in exhalation. Now, obviously, you can't get rid of every cc of air in your lungs, and that's what they're measuring. So if your residual volume is what's left after you cannot exhale anymore, that's your RV. Your vital capacity is your pulmonary reserve and represents the total amount of air that can be exhaled following a maximal inspiration. So now if you look at this graph, the very top of the red line, which is your maximal inspiration, and the very bottom of the red line, your maximal exhalation, together, that's your vital capacity. Now, you could just as easily get a test question that says, what are the three components that make up vital capacity? And the answer would be, it's your IRV plus your TV plus your ERV. That's your vital capacity. Same thing. Okay? Your total lung capacity then is everything. So it's the total volume of the lungs when maximally inflated. So you start way down here, and then you max inhale, but you remember you still have RV that you haven't accounted for. So basically, total lung capacity is your vital capacity plus residual volume. That's your total lung capacity. Then what is FRC? Your FRC is the amount of air remaining in the lungs after a normal exhalation. So really the only difference is normal exhalation is your functional residual capacity. Max exhalation, whatever's left, residual volume. Okay? So that's normally about 3 liters. It allows for gas exchange between breaths. When PEEP is added, it adds a little bit to the FRC, which is why PEEP increases oxygenation. Makes sense? So now that you kind of looked at that whole graph, if you get a little quiz question, time for a live quiz, what do the definitions of vital capacity, functional residual capacity, and expiratory reserve volume all have in common? Are all three of these centered around inhalation, centered around exhalation? Is the focus on height? Is the focus on weight? What do they all have in common? Yeah, they're all centered around exhalation, right? They all have exhalation in common. So vital capacity is your max exhalation after a max inspiration. FRC is the volume after normal exhalation. ERV is the max X after normal exhalation. So the one thing they all have in common is centered around exhalation. So there's a bunch of ways to study this graph, and whatever helps you remember little tidbits about each thing, go ahead and do whatever you need to do. But I'm quite certain you'll see this again, and you'll either have to label it, or it's labeled and you have to define it, or to define it and you have to label it. All manner of ways to ask test questions on this, but man, the reason why we spend so much time on it is because you have to understand this entire graph before you can fly a T1. Because a lot of the decisions that you're going to be making about adjustments on a Hamilton vent are going to be based on your understanding of this. Like, what is the patient's pathophysiology? Is there a problem they can't oxygenate? Is there a problem getting air in? Is there a problem they can't get air out? Like, where's the pathophysiology? You'll never know how to adjust the T1 if you don't at least understand the basic principles of the lungs, which is why we spend so much time on this. So, another quick quiz. If you're looking at your monitor and your respiratory rate is 15 and the tidal volume is 400, then what is the patient's minute volume? This should be pretty simple math. Yes. And how do you do that in your brain real fast? To me, I would just do 15 times 4. 15, 30, 45, 60, add 2 zeros, that's 6,000 mLs. So the answer is minute volume in that regard is about 6 liters, right? That's another super easy test question. In fact, it's so easy it probably won't be on your test question. It probably won't be on a quiz, right? So look to your neighbor, look to yourself, and repeat. You must know this graph, I must know this graph. So all these things you must know. So that was the physiology of breathing, the physiology of the lungs. Central nervous system control, carotid bodies, carotid sinuses, peripheral baroreceptors, chemoreceptors, how we breathe. Now let's look at the hardware and tools of airway management. I know this is seems to be so rudimentary, but you'd be amazed at how many people couldn't name the parts of an ET tube and why it's important. So Murphy's eye, for example, everybody knows what Murphy's eye is, but do you know why it exists? Why does it exist? Why do we have Murphy's eye? Murphy's eye is basically kind of designed to be a fail-safe. So if you get a big old loogie on the end, there's still a hole in the side that hopefully isn't gummed up with gunk that you can still move air in and out from. Murphy's eye is just one of those, it's like a fail-safe. That's what it's designed to do. Now, can Murphy's eye get gummed up with crap? Sure it can. Then that's a problem. That's when you have to do deep suctioning and you're trying to figure out why do I keep getting high pressure alarms and blah, 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 okay? But that's really what it is meant to do. What you'll learn next week is that Murphy's eye is also a great way to add about an inch to your retrograde intubation technique when you pull it through a wire, but we'll talk about that when we talk about surgical airways. But that's what Murphy's eye really was for, is for fail-safe. But you've got your cuff, of course, the pilot balloon, this blue line, which is meant to be what? It's to be able to see it on X-ray. It's your radio-opaque line, so you can see where the tube terminates. Is it in the carina, main stem, whatever? It just makes it easier to see on X-ray. Then you have all these numbers. What do these numbers mean? How many centimeters? Depth, right. The tube size is printed at the top. This is an 8.0 tube. And of course, you've got your standard 15 millimeter connector. You may see double lumen endotracheal tubes. They're not as common as they used to be, but just in case you see a double lumen ET tube, I just want you to know what it is. A double lumen is not the same thing as what did you call that? A combi tube. Those were archaic. But a combi, it kind of you would almost think it's kind of like a combi tube, except this is intended to go into the lung and isolate it anatomically. So the bronchial cuff, you could intentionally left main stem it so that when this is inflated, this lumen will only ventilate the right lung, and then this lumen only ventilates the left lung. The tracheal cuff separating the two lungs from the environment. So basically, you could theoretically hook two different vents up top. So one ventilator is doing the right lung, one ventilator is doing the left lung. I can't actually remember the last time I saw a double lumen. Have you seen one recently, a double lumen being?
I was actually like, what would be the?
Yeah. Yeah, so for example, if for whatever reason one lung is very restrictive, like restrictive lung disease, but the other isn't, or this lung is you've got a transplanted lung which is more diseased than the other one, it's like the other lung, the healthier lung is going to suffer if you're trying to balance the two with one ventilator. Well, the idea is, well, if this lung is pretty healthy and you can just use normal settings and not worry about adding PEEP or increasing your pressure limits or anything like that, but this lung is more sick for whatever disease, injury, trauma, whatever, and it's taking a lot more work with parameters that are way different from the good lung, well, then you can just set a ventilator for it and optimize both. It's hard to just affect one lung to that degree, however, but it can happen, and that's why you have double lumen endotracheal tubes. But I cannot remember the last time I saw one. Yeah, designed to separate them independent of each other. So the gum elastic bougie, oh my goodness, probably the most underutilized tool in our armamentarium, but an amazing tool. How many of you use this instead of a stylet? Wait, so I also have, like, if I have a choice between using a stylet and a bougie as a stylet, I would just use this because it's already there. I have a stylet then, I can still use, I always use a stylet of some kind, whether it's a bougie or a regular stylet, but I like this. The bougies have this little coude tip, which just means it has this little 20-degree bent on the end, which is designed to help it get between the vocal cords a little bit easier. Most people will hold it like that. It's very flexible, and really it is meant to help you with difficult corners, and if you can barely see the glottic opening, but all you see is the arytenoid cartilages and that little interarytenoid notch, bougie's perfect for that, because if you can get that coude tip just above there and slide it through the glottic opening, you know that everything north of there is the airway. So that's always a great tool to then help you, and since you're already there, slide the endotracheal tube right over it into the trachea. Perfect. They do have straight tip ones, but shoot, what's the point? If you're going to use it, use the coude tip. We will talk later on in this talk about how to use the bougie, but right now we're just explaining what things are. The BVM, of course, bag valve mask also, if used improperly, can be a weapon of destruction, because I still see people hyperventilating and overventilating people with this thing. What's the difference between the two, hyper and over? Yeah, so hyper is too fast, over is too much. And a lot of times people are doing both, right? This is July, so don't get sick in July at a teaching hospital, okay? Because all the medical students on Friday become doctors on Monday, okay? So that's why you hear that saying, don't get sick in July, right? So, and their very first code that they're running by themselves, they be like, I'm like, dude, you are not trying to blow up a hot air balloon, okay? This is a person. So, and don't breathe as fast as you're breathing. Just slow, like every 6 seconds, dude, with just your thumb and index finger, that's it, okay? But anyway, if used improperly, it can definitely be a weapon. So make sure that if you've got a student on your truck, if you've got a new doctor on your truck doing a ride along, whatever, that they don't kill someone with this thing. Hyperventilation, overventilating, this is why we often use a small volume bag instead of a normal volume bag. We try not to call it pediatric bag anymore because, people think it's weird using a PD bag on an adult. So I just say low volume versus standard volume bag. Okay. So be able to know this is in your handout, be able to know all the parts of using a BVM. A BVM is not very helpful without like a oxygen supply and tubing, etc. And certainly a PEEP valve can help in many situations. The next thing, blades. McIntosh blades and of course Miller blades. There are many other types like Wisconsin blades and there's a bunch of different kinds, but really the standard ones are curved or straight. A Wisconsin blade, for example, is a little bit of a combination of both, but McIntosh and Millers are by far the most common blades that we use. I personally have always been a McIntosh person. How many are McIntosh users here? Great, no wrong bladers here? Okay, great. I was hoping someone is, so I can tweak them a little bit, but these are standard geometry blades. Standard geometry meaning no height, it's not hyperangulated at all. So when you hear the term standard geometry, just understand McIntosh and Miller. The difference being, of course, hyperangulated. We are toying with the idea of getting hyperangulated video scopes here at SCCAD. We just trialed some. We trialed this one about a month ago. Not trialed, we had them come in and demonstrate for us. This is the Carl Storage glide scope with a hyperangulated blade. The hyperangulated is just what it sounds like. It's like a horseshoe shape. It's hyperangulated. What do you think we use hyperangulated blades for? If you look at the geometry of it, like why would you use a hyperangulated blade? Yeah, you could. Really, the number one reason is you cannot position them optimally for whatever reason. Like maybe it's a 98-year-old super kyphotic person who you cannot like flex or extend even to past, being bent like that. There's no way that you can optimize positioning. Maybe it's a trauma patient with a known C-spine fracture and you can't like align the neck and sternal notch and take the C-collar off. You have to leave them exactly where they are. And you really can't optimize that. The hyperangulated blade is not considered a direct laryngoscopy because it's indirect. You're using that video scope and you are now curving it, leaving the neck totally still and not moving it, and letting the blade and anatomy do all the work. So you're getting around the corner and then looking up at the airway instead of aligning your axes and looking directly at it with a Mac or a Miller. Okay, so that's a hyperangulated. We'll talk about that more, but it's a very different technique. I want to highlight that because it is not the same, you're not at all using the same technique as a standard geometry blade. In fact, we'll talk about that now. The direct laryngoscopy blades. For the McIntosh blade, it is not enough to just set it in the vallecula. A lot of people think, well, I'm going to go in the vallecula and lift. Well, you're missing a step, and that step is engaging the hyoepiglottic ligament. So this is the step that is most forgotten either to be taught and certainly to be reinforced in actual practice. So here, is that a fairly good view? Could you probably intubate that? Absolutely. That's a, 80% POGO score, right? Percent of glottic opening, POGO. Most laryngoscopists could intubate that, no problem. But look how much better it is, that same patient, you just engage the hyoepiglottic ligament a little bit, okay? So it's that, if this were your epiglottis, and it's basically the ligament that lifts it up, and I'm actually not moving my thumb. I'm just pressing down here, and even my thumb will just kind of naturally flip up. That's what the hyoepiglottic ligament does too. So when you engage that ligament up there, it flips up even more. Now you've got a nearly 100% POGO score. So that's what you want to target, not necessarily the epiglottis. Okay, so here's the tip of the blade. It's in the vallecula, yes, but it hasn't really engaged that ligament yet. But now it's engaging the ligament and it flips right open. So just doing that will improve your view tremendously, right? But the Miller blade is designed to go under the epiglottis. And so then you lift it for direct visualization of the glottic opening. What you don't want to do is what I still see people do who use the Miller is they go right down the middle. And what happens when you go right down the middle, you can see in the picture, like a loaf of bread, the tongue just kind of flops around it because it's very narrow. And so now you're really kind of obstructing your view. So really, if you're going to use a Miller blade, going kind of paraglossally and then not sweeping it over like the McIntosh blade does, but you are moving somewhat to the left so that you're not letting that tongue flop over the blade is very important. And notice we're not going right down the middle. we're kind of going down the side. And now you get a much better opening view of the glottic opening. Here's what I don't want you to do. People who use a Miller very often teach, well, just put the Miller all the way in and then lift and then pull backwards until you see cords or until you see it flop in. So basically what are they doing? They're putting the Miller in the esophagus and then pulling back until it flips bloop out of the esophagus and you see airway. And while that might work for some people, I don't want my critical care medics doing that. I want you to know the anatomy, not guess where it's going, and know where that blade is at all times. And we're going to go through that stepwise approach when we talk about the 7 Ps in a moment. But just hold that thought. Do not blindly insert the Miller, see the esophagus, and pull back until you see cords. Right? Please don't do this. The other indirect laryngoscopy blade is when we're using video scopes is the hyperangulated blade, like I mentioned. Small chins, short fat necks, neck flexion problems, C-collars that you cannot take off for whatever reason. The hyperangulated versus standard geometry is going to be way more helpful. What do you notice in the top right picture that goes along with it? A rigid stylet. Okay, that's called a D-blade stylet. It is shaped kind of like a fish hook to match that hyperangulation of the blade. You cannot intubate without it. So they should go together like 2 peas in a pod. Okay, so just like an albuterol inhaler, I don't think should ever be sold without an aero chamber to make it actually work. You really can't use a hyperangulated blade without a D-blade stylet. And we'll show you why in a second. Very different technique. And the technique I'll introduce to you if you're using a hyperangulated blade is up top, stop, drop, stop, pop, drop. Up top, stop, pop, drop. Well, let's start with up top. What does that mean? It means instead of holding the tube in the middle like we normally do, and we hold it like a pencil, you're going to hold the tube like you're holding a hammer or something like that, up at the top. Okay, so up top. Then you're going to stop when you get a 50-50 view on your screen. Not 100%, but 50-50. I'll show you what that means in a minute. Then you're going to pop. You're going to pop that D-blade stylet off the top of your connector, and then you're going to drop that tube right in. But you've got to use that stylet to your advantage and also remove it a certain way like you've never removed a stylet before. It's a very different technique. So look at up top first. So again, that's how you're going to hold it. Up top, kind of like a hammer instead of a pencil. Then you're going to stop when you get a 50-50 view on your camera. This is probably the single biggest error on a hyperangulated blade. People want this great view. They're like, wow, look at that. I got 100% pogo on that. That's awesome. But what do you also notice? Kovacs sign. What is Kovacs sign? Kovacs sign is when instead of seeing the dark blackness of space through the glottic opening, you actually see the cricoid ring. You see tracheal rings. What does that tell you? That means that instead of a nice dark abyss to put the tube through into the trachea, you're going to hit the back wall because your trachea is actually at like an elbow joint, is bent 90 degrees. Are you going to be able to feed a tube through there? No. No matter how good your glottic opening, you're just going to hit that and go doink, 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 and you cannot advance your tube. So that actually is too good of a view on a hyperangulated blade. You want your screen to be 50-50. So that you only see about 50% at the bottom that's blank and only 50% at the top which has the glottic opening. So 50-50 view, way better than 100% view because with 100% with a hyperangulated blade, you're just going to hit the back wall. Okay? So then pop the stylet off with your thumb once inserted. Cooper's maneuver is lifting your D-blade stylet straight up. And here's why you have to use a rigid D-blade stylet. Because if you're using a normal bougie, which is very flexible, if you pull it up, what's it going to do? The bougie is going to bend. If you use even a normal satin slip stylet, it's also more malleable and it's going to bend. This is rigid. Okay, so you are going to lift and actually bring that tube, because it's too low, it'll never go through the trachea, lifting it up and tilting it back. That's Cooper's maneuver. So you lift it up, you tilt it back, and it'll dive right through the vocal cords beautifully. Okay? So pop, lift, and tilt. And then drop. Drop the ET tube. You're going to advance the tube while beginning stylet removal, because remember, you already popped it already. So then you're not going to tilt, you're going to drop it through the vocal cords. But now you've got this rigid stylet. What's going to happen now if you try to push it through the vocal cords? You won't be able to do that because of the rigid stylet. So what you're doing now is you're going to take that stylet out and towards the feet, like a U shape, as you're pushing it in. So you're going to have your stylet there, you're going to tilt it through the vocal cords, you're going to continue to advance, and then simultaneously pull that stylet out like a U towards the feet. It'll come right out perfectly. Okay. Any questions on that?
So,
yeah.
you're holding a high angle laryngoscope.
Mm-hmm.
You have the tube with the D blade.
Uh-huh.
So is it kind of like a two-hand maneuver where you'll be?
Yeah, sure. Yeah, I know what you mean. So once you see it go through the vocal cords, you're in, and you've popped that top. You can either have an assistant hold that, or you can just let go because you know you're in the vocal cords already, and just now with your other hand, take the stylet, start to remove as you're advancing, and then the mistake is people try to go straight up with the stylet, but it's curved like a fish hook, so it's going to get stuck. So you have to curve it out as well, towards the feet. Makes sense? As you're pushing it down. But by then, I know what you mean. You don't have three hands. You don't have to be holding to the scope anymore. Yep. Suction devices for airway decontamination. Has anyone here used a Ducanto yet? Couple of you? For those of you who haven't, you'll be really good at it when we simulate highly contaminated airway in the lab. And we've got all kinds of nastiness we can simulate. Brian and Nate do a great job of that. What we are going to teach you is something called SALAD. SALAD stands for suction-assisted laryngoscopy and airway decontamination. Now just look at the normal suction catheter that we use, which is that. What do you call that? What's the name of that suction catheter? A Yankauer. That's a standard Yankauer. It's in every ER, okay? Although a lot of ERs are now seeing the value and the wisdom of switching to Ducanto suction catheters, because look at the size of that opening versus this. This is made for dentist's office for spittle. It is not at all meant for an ER with beer and pretzels coming at you, or in the back of an ambulance, okay, with beer and pretzels coming at you, which you know you're going to see a lot of that this weekend. Maybe it's hot dogs and pretzels, I don't know, but anyway, it's going to be lots of nastiness. Hamburger buns, oh, it's going to be gross, okay, all of it, okay? But a Ducanto can definitely do much better decontamination for you. The technique is used to basically clean the airway prior to intubation so you have a good unobstructed view of the glottic opening. There are a couple of methods to use a Ducanto. The first one is you can just leave the Ducanto in the esophagus, so as they're puking beer and pretzels, it's just sucking it out of the way and it never contaminates your area to begin with. That's one way of doing it, like this. So you have the Ducanto that you kind of get that whole area decontaminated, you leave it in the esophagus, you go ahead and intubate the trachea. Method number two is when you actually intubate with the Ducanto in the trachea, suction as needed, get all the crap out there, and you can actually do a little combination of both. Now, I've done both, where you go in and you just get all the crap out that you can see, and you still see some crap in the trachea, you can go in there a little bit and get all that crap out, and then either leave it or put it in the esophagus, it doesn't matter. But here, you can feed the bougie through the Ducanto and place it in the trachea. So then you remove the Ducanto, leave your bougie in place, voila, okay? Then you've got yourself an airway after you've decontaminated all the little crap out of it. So method number one, method number two, whichever works for you. Try both. I encourage you to try both in the lab, see which one you like the best, and go with that. Oxygen delivery devices. How many of you thought that 15 liters non-rebreather was high flow? That is not high flow. That is high flow for maybe a non-rebreather. It's high flow for you because that's all it goes up to is 15 on your device. But when we talk about flow, what's the units of measure? It's not milliliters or liters per breath, it's liters per minute, okay? So if as you're sitting here right now and you're breathing, what is your flow? Just physiologic flow rate. In other words, I know that your actual breath only takes a second, but what if you went times 59? 59 more seconds. How much oxygen would pass through my vocal cords in another 59 seconds? That's what I'm asking, right? So your flow rate is not necessarily your amount, but it's how much air is passing through your airways with inspiration in liters per minute. It's closer to 60, not 15, okay? So what we found in COVID early on was a lot of times what our patients needed wasn't intubation. In fact, the early results, because remember, we had no idea what we were dealing with in 2020 when this happened. We were preemptively intubating our COVID patients because of all the stories we were hearing from California and New York that was coming to us. It turns out that they didn't really need intubation. What they needed was just flow support. And so when we actually started putting people on a true high flow nasal cannula at 60 liters per minute, that's all they needed. And we didn't have to intubate them. And their mortality rates went down. So about halfway through our experience with COVID, as we started to figure things out, we realized, well, we try high flow nasal cannula first and then intubate them if they fail that. And so high flow, true high flow is 60 liters per minute, and that's what this device does, okay? So let's talk about low flow. Low flow is actually considered anything less than 20. So 15 liters non-rebreather is considered still low flow. So nasal cannulas, even non-rebreather, Venturi mask, BVMs without PEEP, these are all considered low flow. High flow, if you combine a non-rebreather turned all the way up with a nasal cannula turned all the way up, that's technically more than 20, right? So that's considered high flow. BVMs with PEEP, regulators turned all the way up. Of course, your non-invasive like CPAPs at anything more than 20 liters per minute was considered high flow. But true physiologic high flow would be about 60 liters on a high flow nasal cannula like that is. Now, it's important to know that it's not just any nasal cannula. You have to have the ability to deliver that much oxygen. A normal nasal cannula just can't handle that level of flow. So that's where the Airvo and the OptiFlow comes together. The long and short of it is this, that Airvo makes the flow and OptiFlow handles it or funnels it. So you could put a nasal cannula on an Airvo and it still wouldn't work. Get it? The Airvo makes the flow. The OptiFlow is what handles it or funnels it into your body. So the Airvo is this machine. It creates warmed, humidified oxygen at flows of 60 liters per minute for spontaneously breathing patients. And unlike CPAP, it's not pressure-based, it is flow-based. So they will generate this flow regardless. But at that level of flow, you are naturally creating a little bit of positive pressure. So that's another reason why the COVID patients really did well with this, because they got the flow they needed and wanted, but they also got a little bit of PEEP, right? A little bit of pressure. So it helped as considered somewhat of a non-invasive positive pressure ventilation. Then you hook up the Airvo, which makes the warm humidified oxygen, hook it up to OptiFlow, and that OptiFlow tube, which is much bigger as you can tell, and the cannula that attaches with it will then deliver it appropriately from the Airvo. So you really need both to make the whole system work. We almost ended up, instead of buying ventilators, we almost ended up buying some of these for the ambulance to use, but thankfully the whole thing started to die down before we had to do that. At high enough flows, again, we can provide a little bit of CPAP, but it's not meant for actual ventilatory support. Remember, this is really meant for oxygenation more than anything else. Okay? Oxygenation, even though there's a little bit of some CPAP, it can help with getting rid of some waste, but really it's meant for oxygenation. For continuing on oxygen delivery, we have our regulators. Our regulators can help provide or help either entrain air or just deliver oxygen. So your regulators will do just what it sounds like, regulate the amount of flow you're getting, crank it all the way up. Past the 15 mark, you're getting about 25. But the Venturi devices, you've seen these before, the color-coded plastic things. This is just air entrainment. So how much air are they allowing in along with the oxygen? So you can get a 24%, 35, 31, 28, this is a 40% Venturi. These are all entrainment masks, which will then say, okay, that'll basically give you a 40% oxygenation, 60% normal air. Okay. All right, that's the hardware and tools. Number 3, the process of direct laryngoscopy and intubation. This next section is incredibly important as we set up the 7 Ps of intubation. You know, as paramedics often define themselves as ones who can intubate. Whenever I talk to the new incoming paramedic class at school, I say, so what's the difference between EMTs and paramedics? And almost 2-1, they say, well, we can intubate. And so, you know, the shiny laryngoscope blade is what defines a paramedic, apparently. And I say, no, to me, that's not what defines a paramedic. To me, a paramedic is someone who knows more. And that's what should define a paramedic. Be that as it may, yes, airway management intubation is one of the defining characteristics, but certainly not one of the most important things. Having said that, we know that one of the most critical things a paramedic will need to do is secure someone's airway. Now, it was 1998 when I figured out that EMS was something that I was really interested in and wanted to do. 1999 is when I kind of started my journey into EMS, and lo and behold, the next year in 2000, this paper came out, and I remember this very clearly. Katz and Falk published this study which changed EMS forever in a good way. Well, we thought it was going to be the demise of the shiny laryngoscope blade at first, because what the study found was that 25% of paramedic intubations were in the goose, in the esophagus, unrecognized. And there was very serious consideration nationwide of putting on the guillotine block intubation privileges for medics. They said, we should remove intubation from the paramedic scope of practice and just give them combi tubes or whatever, or esophageal operator airways again, okay? Now, we had all kinds of articles after that in every trade journal. Lawyers like Batson and Dolan made careers out of suing paramedics for missed intubations and stuff like that. Should paramedics still be intubating? These came up back then and still do. I mean, that was from 2020. And the point is that endotracheal intubation is not a single procedure. It is a complex series of actions. And we know that it is not the what that we solved, it was the how that we solved it. What we'll see in a bit is that after we introduced ways to detect esophageal intubations, instead of being undiagnosed, we were able to cut that from 25% to 0%, and suddenly paramedics were still allowed to intubate as long as we were able to verify tube placement appropriately. And that really is the key, which we're going to be talking about here shortly. But I want you to take away from your minds the process of intubation as a procedure, because it's not a procedure. It is putting plastic in the trachea is one part of 59 different things that you're going to do, but it's a series of complex actions. And one of the first things to understand is indications. Like, why would we even want to intubate somebody? I can teach anyone how to intubate. The paramedic should know when and when not to intubate somebody. Heck, I even had a city manager who was a finance guy with zero medical training, and he was walking through the engine bay once of a firehouse, and what are you guys doing? I said, we're training how to use this new scope, and well, that looks cool. He said, you want to try? He was actually very good at getting the tube in. So it ain't, the intubation itself, that's the easy part. It's when do you do it, when don't you do it? That's what's difficult. So hypoxemic respiratory failure is probably the most common reason why we would need to intubate somebody in the field. This is refractory hypoxemia, right? They're not responding to high flow oxygen. They're not responding to, say, non-invasive positive pressure ventilation. They have increased respiratory distress, increased work of breathing. So this is not simply a failure to oxygenate. This is also the inability to breathe adequately. So now we have to secure their airway. So things like CHF, severe CHF or pneumonia, pulmonary edema, ARDS are reasons why we would want to intubate somebody. Now, acute hypercarbic respiratory failure is also a reason. So now they might be oxygenating okay, but they're hypercarbic. They can't ventilate at all. They can't get rid of waste. Note the pH. Because if you happen to see this on a quiz or a test, and of course more importantly on a real patient, This is something you should take note of. Are they acidotic or alkalotic? Acidotic, right? So this should be a clue that they have too much CO2 retention. They're not getting rid of the acids. They're not getting rid of waste. So this is a problem with ventilation. But remember, this is not simply failure to ventilate, because what have we tied it to? Increased work of breathing, respiratory distress, acidosis, not responding to less invasive means. So this is acute asthma, an acute COPD exacerbation, for example, with a PCO2 more than 45 with acidemia. These are reasons to consider intubating this person. Not indicated just as a point of contrast. You've got the same patient, but they're at a routine visit or an MIH visit or whatever, and they're at baseline. Maybe they have obesity, hypoventilation syndrome, chronic COPD. Their stats are always low. Their CO2 is always 55 or 60, but their mental status is fine. They're not acidemic even, which obviously you have to know by comparison, but they're at their baseline. They're not in distress. Their PCO2 is still 50, but now look at their pH. It's a low end of normal, but it's still considered normal, right? And their mental status has not changed. Would you intubate them? I hope not. Okay? So just a contrast, compare and contrast between somebody that you would intubate with acute hypercarbic respiratory failure, but then someone with chronic who's at baseline, you wouldn't, okay, just as a point of comparison. The third reason, so number one was failing to oxygenate with distress. Number two was failing to ventilate with distress. Number three would be airway protection. So they can't clear their secretions. They can't manage their secretions. They have increased work of breathing, again, perhaps respiratory distress, or maybe they're not breathing at all. Aspiration, classic example, overdoses, okay, general anesthesia, acute brain injury, whether that's medical from a stroke or a trauma, okay. Whatever the reason, they can't protect their airway. That's another reason to do it. Number four, you have some acute airway obstruction. They can't swallow or clear their secretions, again, with impending or imminent airway obstruction. So people with angioedema, an obstructive tumor, foreign body, maybe even an expected clinical course, like burns, right? The difference between the ER doc and paramedics is that the ER, by the time the ER doc sees this burn patient, it's been 30 minutes since the injury, where we're seeing the injury 2 minutes after they got pulled out of the house, so they don't look that bad. Well, if you wait till they look bad, you're behind the 8 ball. So if they have indicators of an impending airway obstruction, take the airway sooner. Okay, so this is one of those examples of expected clinical course. Number five, increased work of breathing. We mentioned that in combination with hypoxemia or refractory hypercarbia, but someone's got a high minute volume or high minute ventilation with increased work of breathing. You got to think about the underlying cause, obviously, but things like maybe DKA, sepsis, shock, aspirin overdoses, their work of breathing is such that, man, you really have to worry about deterioration, a kind of an expected clinical course again. You might need to take their airway, but everyone's different. So can you maintain it without intubation, or are you going to have to take their airway? Now, what's the thing you really, really have to remember with these patients? If you are going to take their patient, what's the worst thing you can do? Think about vent settings. Put them on a normal vent settings, right? Turn it on your normal set it and forget it mode. You're not thinking about the pathophysiology behind it. They're breathing 40 times a minute for a reason, okay? They kind of need that. So if you suddenly intubate them and you set it at rate of 12, minute volume of 6 liters, now all of a sudden their pH goes from 7.35 borderline to 7.1, 6.9, and you've killed them, okay? So you need to set those settings to match their minute volume. It's like, okay, what was their minute volume before we intubated? We need to do something to at least try to match that, so we're not creating the acidosis, even making it worse. Okay, so again, you got to think about those things. Number 6, neuromuscular disorders. Expected clinical deterioration like Lou Gehrig's, myasthenic crisis, tetanus, Guillain-Barré syndrome, tick-borne illnesses, things like this, might be another reason why you consider taking someone's airway. Once that decision is made, then, of course, you are thinking about the 7 Ps. And this is where you will be tested on. When you have your practical exam, July 25, and you are doing your actual station practical exam, you will be graded on how well you articulate and perform the 7 Ps very, very deliberately. So this is something you're going to have to know and memorize. Preparation, positioning, pre-oxygenation, pre-medication, paralysis with induction, place and proof, and then post-intubation management. Let's take a look at the first P, preparation. One of the things that I try to tie with this word is preparation, prepare for the race. Anybody used to watch Speed Racer at all? Yep. Yeah, I remember when it was new. You probably watched it on reruns, but it's still a great cartoon. So prepare for the race. What do I mean by that? Well, when you prepare for intubation, think of another acronym, RACER. Resources, access, capnography, emergency backup plans, and recon for difficult airway. Let's look at RA, resources. What do I mean by that? Well, do you have all the help you need? Is this your only patient? Do you have your O2, suction, your Ducanto, your adjuncts, your rescue devices like your eye gels, all these things? Do you have everything you need? You're declaring a status clear priority 2. Remember, every time you say that, you need to tell dispatch whether you want a BC or not if they're not already dispatched. Say, status clear priority 2, send me a BC because they have the rock, right? They have the paralytics. If you're 9664, you'll have the paralytics. So do you have everything you need? O2, suction, all that stuff. Letter A, access. What kind of vascular access do you have? You're going to need good vascular access. You have a line, IV, IO. C, capnography. A colorimetric device is no longer standard of care. Capnography is the standard of care. In fact, it's malpractice if you intubate someone without capnography. No two ways about it. That is malpractice. You have to have capnography, okay? Remember how I said that the CATS and Falk study almost took intubation away from paramedics? Well, Falk was part of the study a few years later that showed we went from 25% to 0 when you had capnography. Okay? So that is why we still have it in our scope of practice. The E in RACER stands for emergency backup plans. You need to have a plan B. You also need to have a plan C and a plan D. Okay? I like to say B for blade. Like if you're always a MAC user, don't do the same thing every time. If you can't get this airway, switch blades or do something different. Do a hyperangulated blade. Maybe not a standard geometry blade. Change something. Backup supraglottic, bougie. Okay, if you're not using a bougie already. Plan C, C for crike. Okay, now understand, you have to decide that here first. Remember, we're not talking about surgical crikes until next week. But it is here in the very first P in the E of RACER that you must make the decision whether you're going to crike someone or not if you can't get it. Because you certainly can't wait until you can't oxygenate, can't ventilate, can't intubate to decide. You have to have already decided what you're going to do. Plan D, just something different. Okay? Do something different. Don't do the same thing over and over expecting the same result. In RACER is recon. Recon for a difficult airway. How do we recon for a difficult airway? Well, here's just another acronym, LEMON. LEMON, you've heard of that before? LEMON is look externally, like is there something that tells you that this might be a difficult airway? Or E, evaluate. Evaluate the 3-3-2 rule. M, Mallampati scores. You all learned that in paramedic school, hopefully. O, obstructed airway. N, neck mobility. These are all things that you'll recon specifically for a difficult airway. When we say look externally, it's like, do they have a short neck, receding chin? Maybe they got giant buck teeth that you know that's going to be hard to get a blade in. Maybe they have trismus, limited mouth opening. Maybe you're running an MVC patient that they just left the surgery center where their jaw was wired shut. Nightmare, right? What are you going to do now? Okay. Severe osteoarthritis of the cervical spine. They can't even flex or extend their neck. Okay. What things look externally? Maybe they've got a giant grizzly Adam's beard, so it's going to be hard to do a BVM and oxygenate them up. Look externally for physical problems, but you also want to look for physiologically difficult airways. Like, is this an acidotic DKA you're about to intubate, where you've got zero reserve? Maybe they're a hypoxic asthmatic and the best oxygenation you can get is 88%, the best. You're starting behind the 8 ball, right? Those are physiologically difficult airways versus physically difficult airways. Looking externally, reconning, okay? Evaluate for 332. What do I mean by 332? The 332 rule refers to the finger measurement. So can you fit 3 fingers in the mouth? If not, you know that you have limited mouth opening and it's going to be much harder to get the blade in. Or even in a supraglottic in for that matter. The second 3 is, what is the hyomental distance from the jaw or the mandible to the hyoid? Can it accommodate 3 fingers, yes or no? If not, you're going to not have enough area to lift the jaw forward or engage the blade, right? If they have micrognathia, which is the name for a small receding jaw or very small mandible, you can only get 1 finger or maybe 2. You're going to have a much harder time engaging the blade. Okay? Number 3 is the thyrohyoid distance, 2 fingers. So that's 332. In other words, is it enough to even visualize the glottic opening, or is it going to be very, very anterior? So 3, 3, 2. Okay. M, Mallampati score. Just as a quick review, if you see that when they open their mouth, assuming you have the luxury of saying, say ah, okay, that's what they think, that's what it predicts you're going to be able to see, all right? But if you see that when they say ah, oh my goodness, you may not even see the epiglottis. You may not even see the interaortic cartilages. This is somebody that you might want to consider a hyperankulated blade if you had such a thing. Okay. O, look for obstructions. Okay. Foreign bodies, hematomas, trauma, massive trauma, vomiting, blood secretions, angioedema. Okay. This and this are actually quite common. What are those 2 things from? What drug? ACE inhibitors. A couple times a year I'll see that. Just one, there's a weird thing, just one lip, not both. Sometimes it's both. Some of the worst nightmares, the worst airway nightmare I had was a lady who was on lisinopril, ACE inhibitor, and she looked like this. Her tongue was so swollen, and her upper and lower lips were also swollen. This was like, this is bad. You know, we cannot intubate her. But we knew we had to get an airway somehow, and I didn't want to crack her because she had no landmarks. I'm like, this is a nightmare. So nasopharyngeal we got fiber optically. This is going to be a problem, right? Massive problem here, problem there. This maybe not, but at least you notice that that is some anatomic problem. Okay? And then of course neck mobility. If you cannot optimally position them, because as you're about to find, positioning is the most important aspect of the 7 Ps. For the physical act of putting plastic in the trachea, and if you can't do neck mobility, that's a huge problem. So neck mobility is the N in lemon. So why should we care so much about the first P, preparation? Here's why, because if it takes you 2 or more attempts to intubate somebody, people die. And we've always kind of known that, but since 2012, these studies have shown 2 separate, 1994 and 2012 actually. 1994 study, more than 2 attempts, DSATs increased from 12% to 70%. Cardiac arrest rates increased tenfold, right? 2012, 3 or more attempts were associated with cardiac arrest, dysrhythmia, hypoxia, aspiration, right main stem. All these bad things were associated with multiple attempts. So in other words, if you can prepare with Racer, Lemon, and prepare yourself mentally, physically, with all your stuff, increase your first pass success rate, mortality literally goes down, okay? So fewer bad things happen. The corollary, if you finish Racer and you determine that, man, this patient is not a good candidate for endotracheal intubation, and you believe you can sustain them to the ER with less invasive means, then by all means do that. You probably should, okay? Because we don't want you to perform endotracheal intubation if you feel like you couldn't, they're not a good candidate, and in spite of all your tools and stuff, you're like, I'm really afraid about this. But you can sustain them some other way, then that's probably what you do. That's the whole point of recon, okay? So being unprepared is bad, okay? Okay? Okay. So be prepared. Summary, RACER, resource, access, CAPNO, emergency plans, and recon. Okay, you recon using lemon. Number 2, second P is positioning. Positioning is key, changed my mind. And this is probably the primary determinant of first pass success. If you prepare with RACER, lemon, you're ready for anything, primary determinant of first pass success is going to be positioning. Okay? What is wrong with these examples of positioning? They are way too hyperextended. I got to tell you, I'm embarrassed to say it. I used to teach this. I remember teaching, because this is what was taught back then, is if you can hang their head off the edge of the stretcher, you know, that would be good. I mean, it kind of, sort of makes sense, but not based on what we know now, okay? The funny thing is, this anesthesia journal back in 2014 said, any position that looks uncomfortable probably is not an optimal way to position somebody. And that looks uncomfortable, okay? This looks much more comfy. And what do you notice about this positioning? Could you fall asleep in this position? You sure could, okay? Could you fall asleep with your head hanging off the end of the bed? Probably not, okay? If you're really tired. I mean, normally, probably not, right? So this is much, much more comfy. What you notice about all 3 of these pictures is that the ear and sternal notch are lined up, okay? The external acoustic meatus, or ear hole, okay? But you're critical care paramedics, you can't say, I lined up my sternum with the ear hole. You gotta say, I aligned the sternal notch with the external acoustic meatus. That's what I want you to document, okay? So, nice straight line. And that actually ear to sternal notch alignment really, really optimizes the angles from a physics standpoint to see a much better percentage of glottic opening. Notice, we're not hyperextended, the face is not cranked looking back, it's parallel to the ceiling. And if you can choose ramping over just sniffing, that's even better, okay? So, ear to sternal notch. What's interesting is that the model used for this picture, she almost fell asleep during the photo shoot because it was so comfortable. She told the photographer, when I go home, I'm getting me some blankets and rubbing in my bed like that. She was for real. Because look, that's uncomfortable, right? This airway is wide open. When you see someone who's in respiratory distress, like a really bad asthmatic or be a bad CHF, they can't breathe, are they lying down on the couch? What are they doing? They're tripoding. What does tripoding do? This. It lines up the ear. They put their neck forward. They're sitting up, right? It makes the airway as wide open as possible. They're not looking up at the ceiling. Their face is facing you in the front door. As soon as you walk in, they're facing you and looking forward. They're bringing their airway forward. They're opening the airway. And that's essentially what you're doing this way. And optimal positioning for lining up the axes. Okay. Number 3, third P of 7 Ps is pre-oxygenation. Remember, start with suctioning if you need to. Decontaminate that airway. Our airways are not the surgeon's airways and anesthesiologist airways where they've been NPO for 24 hours. They got nice music playing in the background, right? It's climate controlled. No, we're in a friggin' ditch with someone who just got ejected in the rain with mud in their throat, right? I mean, that's our job. So, oxygenate the lungs, don't oxygenate mud. Get all the gunk out of the airway, suction, get your Ducanto out, make sure you add suction unit to your truck checks because that's really, really important, okay? Is suction unit on your truck checks? Hopefully it is. If it's not, you should probably add that to your truck checks, okay? While preparing the final steps to intubate, you may as well put them on some oxygenation. So extend that safe apnea time interval during the intubation process. You're extending the intubation window, essentially. What we mean by that is safe apnea. What does safe apnea mean? Well, once you push a paralytic like succinylcholine or rocuronium, they stop breathing, right? And so, in other words, your safe apnea time, how much time do you have between the minute they stop breathing and the minute you deliver oxygen via a tube? That's the question. Is it 90 seconds, 2 minutes, 7 minutes? Because if it's 7 minutes, you have a little bit more time to get that airway. If it's 90 seconds, not so much, okay? But everyone's safe apnea time is going to be different. But we know that It's going to take you a couple minutes to get all your equipment right and everything. Well, get them on oxygen during that time. Pre-oxygenate them and increase that time window that you have. And that's what pre-oxygenation does. In fact, can anyone explain this graph? I could see this easily as a test question, right? Question number 1, explain this graph. What does this graph tell us about the importance of, specifically about the importance of pre-oxygenation? What does it tell you?
Higher the SpO2 percentage, higher the PaO2.
Okay, let me ask you this. So the x-axis is your oxygenation, PO2, right? The y-axis is what? Your SpO2, which is what your pulse ox says, right? Okay. You've got 2 patients. They're both at about 96%. Will they have equal safe apnea time? Okay. So what is this graph saying?
Even though that you may have like a higher SpO2, you might not have a high PaO2.
Correct. What this graph is saying, if this was on a quiz question, I would explain it this way. I would say all 96%ers or 95%ers are not equal because both these patients have an O2 sat of 95%. Yay! Pulse ox is 95%. Go ahead and push the rock. Well, wait a minute. This person is at PaO2 of 80 with a 95% sat. This patient is at a PO2 of 600 with a sat of 95%. Who has a longer apnea time? 600 does, okay? 80, you might have 45 seconds before you start falling down a cliff. This dude may have 5 minutes before you fall down a cliff, okay? So the point is, will you be able to tell without an ABG machine where they are in the PaO2? Shake your heads no. So just assume, even if they're 95%, you should try to oxygenate them some more because you don't know if their PaO2 is 80 or 600. You might as well make it 600 if they're not. Okay? So much lower risk past 100, much higher risk 60 to 80, 60 to 90-ish. Okay? So that's how you explain that. Okay, so now the question is, okay, but how? How do I pre-oxygenate people? Well, there are multiple ways to pre-oxygenate people. You can do 3 minutes of a full tidal volume breaths or non-invasive positive pressure ventilation on oxygen. That is considered to be a full nitrogen washout. Okay? Now, understand that the 3-minute timer begins after you get the SpO2 as high as you possibly can. So if you start at 88% and you give them O2, and now it's 90%, the clock doesn't start at 3 minutes now. After a couple minutes, you get up to 96%, great, and they stay there, they're not going any higher than 96%, then you start the 3-minute timer. Okay. Now remember, if it takes more than 3 minutes, so be it. If you have the luxury of that time, okay, they're not actively aspirating, they're not distressed, they're not tiring out, there's no obstruction, right? You have some time to do it, let it be. You know, get that full oxygenation, especially if you think that this might be a little challenging airway-wise, maybe, okay? You can maybe roll the dice a little bit if you think that this should be a pretty straightforward airway, I can get this. Maybe 2 minutes is enough, I don't know. But if you can do the 3 minutes, go right ahead. 3 minutes will seem like a very long time when you're on scene, I guarantee it. But we're already at about 90 seconds left is all you got. So it actually is pretty fast, okay? So do a full nitrogen washout as soon as you can and buy yourself a little bit of time, okay? Get your PO2, SpO2 as high as possible. Now, remember, below 93%, that predicts some complications. So your goal is to get at least above 93%, 94 and above if you possibly can. Statistically, 93% before ETI predicts desaturation, maybe even immediately, okay? Dr. Weingart and Dr. Levitan are probably the 2 most prolific emergency airway authors in the world, not just the country. So I would definitely listen to what they have to say. Using positive pressure ventilation with PEEP for washout is a little bit better for patients with hypoxemic respiratory failure. Why is that? Why does PEEP help in this case? Keeps the alveoli open a little bit longer. Yes? Oh, I did it again. This is really weird. Okay, what's another reason why it's good?
If you have more PEEP, it can open more alveoli up for gas exchange.
Good, that's the second reason. So good. It prevents alveolar collapse, yes, and it recruits collapsed alveoli. So you got both. So when you do both, More alveoli means greater surface area for greater diffusion. So that's exactly why we want that. So that's why it helps oxygenation, okay? And then you also have to therefore know how to use a BVM in that case. So probably the single most important skill in airway management is, interestingly enough, using a blade, it's using a BVM. As we said, it can be a weapon if used improperly. So because it's BLS, it often gets overlooked as an important skill, especially by paramedics. Well, that's beneath me. That's for the first responder. That's for the BLS guy. When in fact, that's probably one of the most important jobs ever on a scene. What do I hate about this picture? It's in almost every textbook, EMT and paramedic, and I can't stand it. What is wrong with this picture? How what? Actually, the tongue is that big. It actually attaches to the mandible. Yeah, this part's all you can see, you know, but.
It's not supine, so the anatomy changes when it's supine?
The anatomy does change a little bit when it's supine, like the tongue will fall back to the back of the throat if they're supine. That is true. But what I hate about this picture is the esophagus. Is it really open like that? Is the esophagus really open like that in real life? Yes or no? No. In fact, if I showed you an actual x-ray or even a CT scan of someone's neck, where's the airway in this x-ray? Right there, right? That's a trachea. There's the epiglottis right there. There's no esophagus. Here's a CT scan, even more detail, right? There's your epiglottis. There's your trachea. There's nothing back there. There's no esophagus, right? So did these patients have esophagectomy? It's just collapse, right? The difference between the esophagus and the trachea is that the trachea is stented open with rings. The esophagus is a potential space, right? It's not actually a tube until food goes down or water or something. Then it just collapses to nothing.
You'd be having real bad breath.
Really bad breath if you could, yeah. If the esophagus were wide open, can you imagine the smells like, hello, good morning, oh, whoo, okay? So why are we talking about BVM in a critical care class? Well, it's because most people do it wrong, okay? They're doing it wrong. First, 4 things: seal, adjunct, pressure, and volume. You have to have a good seal. You've got to use an airway adjunct, usually. Some don't, but some think they're too cool to use an adjunct. But like people say, I never use a stylet to intubate, as if that's a badge of honor. When I hear people say that, I say, you're an idiot, okay? Use a stylet, use an adjunct, use an OPA, NPA if you're bagging somebody. That's what it's for. Number 3, low pressure. Number 4, low volume. The point is this: air wants to go in the trachea. If you have a good seal, if you've got an effective adjunct, it doesn't take high pressure or high volume. Air is going to want to go down the path of least resistance into a wide open trachea, right? If the esophagus really were open like that picture shows, like so many of these ridiculous illustrations show, then air would equally go into the stomach and the lungs, right? Which is bad. So first, seal. I know that most of you have learned the EC clamp. That's how I learned it. But now over the last few years, we stopped teaching the EC clamp because most rescuers are not by themselves. Certainly in the ER, like we don't teach the ER residents how to do EC clamp. In the ER, you're never by yourself in the ER. You've got a nurse, a tech, a security guard. You got somebody to help you. So we teach the 2 thumbs down technique, okay? The good old EC clamp, very often people anchor on the neck instead of anchoring on the mandible, and they just choke people on the soft tissues of the neck, invariably. I still see it today, okay? The 2 thumbs down technique is even better. When you're in the lab later on, I invite you to try it. I invite you to try to do the standard EC clamp like you've always done, and then do the 2 thumbs down technique. I have kind of smallish hands, and my hand, after 5 minutes of pre-oxygenation, it cramps up. I don't know about you, but I can't hold a good EC clamp that's tight and get a good seal for 5 straight minutes. Okay, I cramp up. With a good 2 thumbs down technique like this, and I'm pulling the jaw up into my mask, I can hold that pretty good, okay? And so when I get a good seal, I got my oxygenation in place, my PEEP valve is on, I'm preventing alveolar collapse and all that stuff with some PEEP. Oxygenation becomes optimal when I can now improve FiO2 and PEEP now? Yeah. So when would you not increase PEEP, or at least be cautious about increasing PEEP? That's not a bad idea because you're increasing their thoracic pressure and they're already hypotensive. Yeah. Yeah, I guess if you're worried about venous return, that might be something that you're thinking about. I'm thinking more for like people that has already mostly already barotrauma. Certainly hypotensive is one, but beyond valley, what's a valley? Ventilator-associated lung injury. Beyond valley, overdistension can actually worsen arterial hypoxemia because you're making VQ mismatch even worse. Okay, so we don't want to overdistend the lungs either. So just be mindful. It's not necessarily a contraindication, but just be mindful of it. If the patient's already hypotensive, if they already have barotrauma, perhaps, don't make it worse by overdistending them either. Okay.
What about patients that have like traumatic, like pneumothorax or pneumothorax, stuff like that? Obviously giving them enough PEEP to recruit those alveoli and open that lung back up.
Yeah.
What are your thoughts on like increased PEEP for those patients if they do have like poor oxygenation?
Well, PEEP is decent to help with oxygenation, but if it's from something physical like a pneumo, for example, the solution is not PEEP, it's reducing the pressure. I would focus more on that, but afterwards they'll be bound to have some collapsed alveoli and atelectasis, then PEEP is great for that, to reestablish that, pop them back open again. I like that, yeah. I'll often do that for patients. What I'm doing is I'm double checking because it seems like some of my slides got whacked out of place. I've got a BVM seal. Okay, we're okay. All right, so now, still in the pre-oxygenation phase, we've optimized our BVM. We know how to use the BVM properly. There are other various techniques with pre-oxygenation. Either a nasal cannula and non-rebreather, like we said, is considered high flow if it's more than 20. The BVM with PEEP and nasal cannula, the nasal cannula at 25 with non-invasive, like CPAP at 25, or OptiFlow at 60. Okay, notice the amount of entrained air from top to bottom goes from least amount to greatest amount as you go from top to bottom. Okay, with high flow nasal cannula being the highest flow rates. So we've discussed optimizing oxygenation in preparation for that apnea time during RSI. Is there a way to continue oxygenation during the time of oxygenation while intubating, during the safe apnea time? Can we continue oxygenation while they're apneic, while during your attempt? Yes, there is actually a way to do it. Not everyone does this, but especially for those patients who you're a little bit worried about safe apnea time, this is another trick that you can add to your toolbox. And that's called no DSAT. You ever heard of that before? No DSAT is another acronym. It stands for nasal oxygenation during efforts securing a tube. I know that's a stretch, but it works, right? It spells no DSAT. Nasal oxygenation during efforts securing a tube. What does that mean? It means that most of the time you pre-oxygenate somebody, you push your sedative and your paralytic, and then they're apneic and there's nothing else on their face. You've stopped bagging them, you took the mask off because you got to intubate them, right? So they've got nothing oxygen-wise, and so you're depending on that reserve in their bloodstream, which for the most part will be fine. But for those patients that you're kind of concerned, you can add no DSAT as a way to continue oxygenation. And there's a lot of techniques to do this. One way is a nasal cannula turned all the way up, so just a normal nasal cannula all the way up. Or you can actually put the OptiFlow on like they've done here at 60 liters. So that's actually providing a little bit of CPAP as well. So high flow O2 while you've got the blade in their mouth. So even though they're apneic, you're still getting some O2 down the lungs. Is blood still flowing through the lungs? Yes, hopefully. Okay, so they're still picking up some of that oxygen. Are they ventilating during this time? No, not really, but hopefully you'll take care of that really soon. But at least you keep some oxygen going. So that's just another way of providing no DSAT. In other words, while they're apneic, okay? So some pro tips to optimize the no DSAT process. No DSAT. Bed up, head up. So again, we would rather have ramping as opposed to simply sniffing position. So if you can ramp them up like that, that's great. Bed up, head up. About 20 to 30 degrees, you've got your airway adjuncts to help that oxygen get down as deep into the lungs as possible. Flow rates at least 15, but ideally more than 30. It's all about flow, right? It's all about flow. So things that don't help, that is just a failure, is if you do blow by, right? I can get stuck down the Stephen He rabbit hole for 3 hours watching him. He's so funny. But anyway, have you ever seen people put a non-rebreather but not on their face? It's like next to them on the bed? That doesn't work. It just doesn't work. Okay, so don't do that. Passive BVM, supine position, not oxygenating them first. Okay, that's all a failure. Don't do that. Okay. So we've talked about preparation. We've talked about positioning, pre-oxygenation. Now we talk about the fourth P, pre-medication. Now, yeah.
Sorry, to go back to that, that no DSAT, how long do you think that extends their their safe apnea?
Oh, that's a good question. For those of you watching, he asked, how long does no DSAT extend their safe apnea time? Well, just like safe apnea itself, it depends on where you're starting. So if the best you can get is 200 PaO2 for whatever reason, well then you're still going to have a much shorter time than someone at 600. We don't know at the time. We just know that it extends somewhat, so it depends on their underlying pathophysiology. It might add a minute. It might add 3 minutes. Both are better than not having it. So the point is eking out every second of safe apnea time you can. And the no DSAT process is just one of those tools to do it. So I couldn't tell you that no DSAT adds 5 minutes, because that would be wrong. It depends what their underlying pathophys is. I think it's safe to say it adds time. I couldn't tell you how much. Like,
so there's not like a safe, like, okay, I put this nasocanial on them, I got an extra like 45 seconds for their safe. There's not really a safe.
there's not really there's no way to standardize and say this always gives you an extra 45 seconds. This always gives you an extra 3 minutes. I just don't know.
Yeah.
In fact, Levitan himself often says, look, all these things we're talking about is theoretical, and it all depends on the patient's underlying status. He says, you can never assume that you even have a safe apnea time, because he says, in my experience, I've had a couple patients across my career, he says, where I've done all the things, and the minute they go apneic with the paralytic, they start to drop their sats, and I gotta get this too. And so, he'll tell you that, yeah, it adds time, but you can't say how much. That's a really good question, though. Any other questions? All right, pre-medication. A lot of people think that this step, pre-medication, is to give your sedative, like etomidate or something. You pre-medicate them and then you put the tube in. That's not what pre-medication means. Pre-medication means before you give a medicine, not pre-medicate with Versed. It means before you push the sedative, what do you do? So that's what pre-medicate means. Translation, this is not where we give the RSA meds, you big dummy. You ever watch Sanford and Son? He's hilarious. You big dummy. This is not where you give the pre-medication. This is when we assess the patient for risk of a hemodynamic crash, okay? And we treat and prepare accordingly. So pre-medication means before we push the medication, are we optimally optimized before we actually do? What should we address then before we push the meds? Before medication, pre-medication, we should be intentional about looking for the H-bombs. H-bombs like hypoxia, hypotension, hyperventilation. This is badness for all, not just TBIs, but for all patients. What are their vital signs? What's their BP, heart rate, SATs? Can we optimize their fluid status? Can we optimize their ventilatory status, blood pressure, oxygenation? Are there any dysrhythmias we need to address before we push the meds? Are they in a ton of pain? Are they hyperkalemic, perhaps? All right, these are all things that we should address, if at all possible, before we push the RSI meds. So if they're hypoxic still, is there something we can do about it? Hypotensive, what do you think is going to happen if we push propofol or Versed or etomidate and they're already starting at a pressure of 90? Not real good, right? Bad things, okay? So can we do something to get their pressure over 100 before we push the sedatives and the paralytics? Things like that, okay? Do we need to give a defasciculating agent before the neuromuscular blockade full dose? Like if you give 1/10 of a dose of the rock, will that help any? After you've addressed those H-bombs and optimized them as much as possible, then P number 5 is your paralysis with induction, okay? So another live quiz real quick. When we're talking about intubation, the term RSI stands for A, B, C, or D. I've heard equal B and D. I have not heard anyone say A yet or C. So it sounds like it's between B and D. Is it rapid sequence intubation or induction? Most people think RSI is rapid sequence intubation. In reality, it's induction. And this is an error in your textbook that you should cross out, because it does say rapid sequence intubation. Done properly, there's nothing rapid about intubation. The induction is rapid, but the intubation process itself is not rapid. There's nothing rapid about this. Okay, we've been talking for an hour now. We haven't put plastic in the trachea yet. Okay, you've done all you got to do. And when you see the live demonstration this morning, this afternoon, you'll see it's not rapid. What's rapid is the induction process. Okay, so the performance of RSI, when you hear people say, I RSI'd him, okay, people use that to be synonymous with intubation. When they say, I intubated him, they say, I RSI'd him. They're not the same thing. RSI presumes the use of a paralytic, okay? DFI, or drug-facilitated intubation, most people, when they say that, they mean they only gave a sedative. They only used Versed. They did not paralyze them, okay? But RSI presumes the use of a paralytic agent. Would you ever paralyze somebody without a sedative? I sure hope not. I sure hope not, okay? That's cruel. You should have an induction agent to induce general anesthesia, followed immediately by a paralytic, either a depolarizer or a non-depolarizer. Doesn't matter which order you push that. Do you do the paralytic first and then the sedative, or does it matter? Sedative first and then paralytic. We give this, I hope you give the sedative first, right? Sedative first and then the paralytic, all right? Why do we say immediately? Because the primary purpose, and this is the rapid part, this is what the rapid refers to, is the induction of general anesthesia followed by a paralytic. That's rapid. Okay. The number one reason why we give a paralytic is to paralyze the diaphragm. Everybody thinks it's to paralyze the jaw, to make it easier to intubate. That is a reason, but that's second to paralyzing the diaphragm. Why do we care about paralyzing the diaphragm? Because no diaphragm means no vomiting. They can't vomit without a diaphragm, right? No vomiting means no aspiration. No aspiration means no death. No asphyxia, no death. Okay? Aspiration is what has killed so many of our greatest musicians. Like John Bonham from Led Zeppelin. He was 30-some years old and died from aspiration. He had a post-concert party, I guess, and drank and was so intoxicated, he passed out on the couch and vomited and choked on his puke. Bon Scott, lead singer AC/DC, same thing. I mean, right? Brilliant musicians from aspiration. So the second reason we give the paralytic is to optimize blade insertion. But number one is paralyzing the diaphragm so there's no vomiting, okay? If you have no trismus, then there's no delay. No delay, there's no hypoxia. No hypoxia, no brain damage. Okay? So you should be able to articulate that on a test question and say, what is the purpose of the paralytic? Number one, no diaphragm, no vomiting, no aspiration, no death. Number two, no trismus, no delay, no hypoxia, no brain damage. Okay? That is why we give that paralytic agent. Then, once you do that, you must very quickly place and proof. Okay? That is P number 6, place and proof. You've waited your 30 to 60 seconds for the sedative and the paralytic to take full effect. That's important as well, because the biggest mistake I see, the thumb pushes down on the sedative, thumb pushes down on the rock or the sucks, and then they stick the blade in the mouth like 10 seconds later. I said, what are you doing? They're not even paralyzed. I mean, nothing has taken place yet. What happens if you stick a blade in someone's mouth before the diaphragm is paralyzed? Now you just made him puke. Now you just shot yourself right in the nutsack. Okay, so you gotta wait. Let the medicines do its work. Continue to know DSAT, keep bagging empty, whatever you're gonna do to optimize oxygenation. And then communicate with your partners, okay? Because after all, the last thing you want is for someone to push the RSI meds before you're even ready. So make sure that all through this time communication is happening. Because if you don't, that is a fail, like this person on a trampoline, boom. So once paralysis is achieved, like I said, place and improve. How do we place? Suction, scissor, series. Suction, scissor, series, okay? So suction, we talked about the importance of salad and Ducantos. Use it. Maintain your no DSAT from the pre-oxygenation phase, okay? Scissor, mechanical advantage is with the first and third fingers, not your first and second. So first and third fingers, scissor that mouth wide open, get as much airway opening, get that 3-3-2, remember that? Get all three, get a number 3 opening if you can, and prep blade insertion. Series, a stepwise, systematic, and pre-planned action to culminate in placing the plastic in the trachea. This series of actions includes proper grip, side alignment, visualization. This is what I mean by don't just put the blade in blindly and hopefully you see cords. Knowing your anatomy types and even proper shaping of your tube. Let's look at proper grip. A lot of people are still holding it like this, where they're holding the handle and the blade is down here, okay? What is the advantage of holding it like that?
You get more control of the blade.
You get way more control of the blade. If I'm like this, now I have 2 moment arms. I've got this one and I've got this one, okay? And even the slightest motion, I'm going to be moving the tip of this blade, which I may or may not want, okay? But if I'm holding it like this, I have 1 leverage point. My forearm and my blade are 1. My radius on the blade, 1. Instead of 2 vectors of forces, or 3 actually, I have 1 vector, okay, to control. I have much more fine control over the tip this way, pitch, yaw, and roll, both, all 3 rather, okay? So a lot more power. The other thing is I'm much less likely this way to break teeth and crank back as I am this way. This way, that's easy. That's almost natural to crank back on the teeth. Okay, this way, I'm reminded I'm lifting Statue of Liberty style instead of this way, okay? Which is what I want. Notice also the correct elbow positioning. You're not like this, chicken winging it, okay? You got your elbow in close to your body with it like this, that's a power. You can really lift good that way, okay? If you look at our operators overseas, they're not going through the house with a rifle like this, right? They're like this, okay? They're going through the house. Much more control, much more power, okay? So same thing with the laryngoscope blade, okay? Scissor technique, again, better mechanical advantage, first and third fingers, not first and second. So notice the thumb is on the bottom, third finger, top, and you're scissoring, okay, like that. Get the widest possible opening for your blade. Side alignment. If you ever see someone intubating and they're doing this, their head is going back and forth like a chicken, you know? They don't know what eye they're looking at. Should you keep both eyes open when you're intubating? Yes. But know this, you're not using both eyes. You're really using one eye. You just don't, you have to realize which eye you're using, okay? Do you know what dominance you are? Do any of you know what eye dominance you are? No? Okay, this is actually really important. So pick a spot, like pick this corner of the TV or the top corner, I don't care. Yep, Solomon knows what I'm doing. Then you make a little pinhole with your thumbs like this. Out here, can you see the thing you're focusing on? Now slowly bring that to your face until only one eye is looking at that point, whatever point you're looking at. And whatever eye you are over, that's your eye dominance. Are you left-eyed?
No, I'm just.
You're trying?
To the left eye.
Who in here is right-eyed? Solomon, you right? Colin?
I guess I'm left.
Are you right-handed?
Yeah.
Okay, so he and I have something in common. Only about 2% of the population is right-handed, but left-eyed. Most people who are left-handed are left-eyed, and right-handed are right-eyed. Your eye dominance and your handedness is usually the same. But about 1 or 2% is cross dominance. So yeah, did you guys ever see Firebirds with Nicolas Cage? It's an old movie, like 1990s. Anyway, he's a fighter pilot in an Apache helicopter, and he can't fly because their reticles are all right-eyed, because everyone's right-eyed. But he was left-eyed and didn't know it. And he couldn't hit his target, he couldn't watch the FLIR, he couldn't, like that. No one could figure out what is wrong with this guy, he's an idiot, until the instructor said, put the reticle on your left eye. He was great, right? I'm on the range years ago, and I'm shooting my rifle, and the instructor says, Doc, put the rifle in your left hand. I said, okay, but I'm right-handed. He said, just do it. So I put it in my left, and all of a sudden, I'm putting the bullet through the same hole. He says, did you know you're left-eyed? I said, no. What does that mean? And he says, well, that means your dominance is left. And when you have to look at something like a scope or a pistol sight or intubation, you're only using one eye. So you need to know what eye dominance you are, and that's what eye you're using. Okay, so Colin, if you're left-eyed, then when you're intubating, you're going to look like this guy using his left eye, not this using your right eye. Okay.
I intubated 3 days ago, and I was looking at it with my left eye. I very vividly remember doing it.
Yep. So you're left-eyed. So you should be sure that as a left-eyed laryngoscopist that you are. Notice both eyes are open. Just like when you're pistol shooting, you don't want to close one eye. You're still both eyes open, but you're only looking down your whatever dominance you are down your front sight. Okay, so same with intubating, because if you think about it, what are you looking at? You're looking at your glottic opening, right? And your glottic opening is about the size of a what? Dime, nickel, penny, quarter? What? It's the glottic opening. It's about the size of a quarter. If you take a 25-cent piece and that's about how big it is, trachea, what glottic opening on an adult, and you're looking down a paper towel roll, right? You're looking down a tube at this thing the size of a quarter. Well, you're not looking at both with both eyes. You're like I'm looking at it now through my left eye. So now that you know what eye dominance you are, you'll know how you should be looking down someone's gullet when you're trying to intubate. Okay? Blade insertion. Remember, we're not just sticking it straight in. The handle should be pointed at the feet first, because if you're a Mac user, which most of you are, you got to follow the curvature. Okay, so putting it correctly is a key, because you have to visualize it in a stepwise series of actions. Then, as the blade follows the curvature of the tongue in the vallecula, you'll notice the handle is now tipping from the feet up towards the ceiling, and that's what you want. Okay, but first you got to find out where the epiglottis is. This is why you can't just stick it in and look. I follow the blade all the way down, and I find epiglottoscopy is the very first step, because if you're using a Mac, it's got to go above the epiglottis. If you're using a Miller, it's got to go under it. Well, how are you going to do that if you don't know what the epiglottis is? Epiglottis camouflage is a thing where some people have a floppy epiglottis where it's like sitting on the back of the pharynx and you can't even see it until you wiggle the blade a little bit. Now then you can kind of see it moving on the back. Oh, there it is. Now you know whether you need to go under it or over it, and you can appropriately visualize where that blade is going. Okay? Then engaging the hyoepiglottic ligament, not just putting the tip in the vallecula, but engaging that ligament and then lifting up. But your sequence should not be this, which is what most paramedics do. They say, put the blade in, lift, don't break teeth, hope you see cords, and hope that you get the tube through the cords. And that should not be your plan. Okay? You need to say to yourself, self, I got my blade, I'm going to watch this blade go past my lips, my teeth, my tongue, see my little dangly thing, uvula, right? But I still say dangly thing to myself. Okay, lips, teeth, tongue, dangly thing. And then I do epiglottoscopy. Where's my epiglottis? Then I look for my posterior cartilages, which is these nubbins here, right? The arytenoids. Then I look for the interarytenoid notch. Then I look for the glottic opening. And look, the last thing I'm looking for, vocal cords. Whereas for a lot of medics, it's like, put the blade in, lift, and look for cords. They skip everything else. I'm like, what are you doing? It's no wonder you have a hard time finding what you're looking for. So there's the tongue, there's the dangly thing. Now, where's the epiglottis in this picture? You can't see it because it's camouflaged against the back of the wall. But if you wiggle the blade a little bit, suddenly there it is. You can see the tip of it lift up off the back of the pharynx. Then you look for your posterior cartilages. There it is. There's the interarytenoid notch. There's the glottic opening. Can you see cords there? Not yet, because you haven't lifted it fully yet. Now, there's your cords. That's a beautiful view. That is what I wish upon all of you every time you intubate, that you see that. Okay? So, what if you do everything right, and that's the best you can see? You can see the posterior cartilages, you can see the interarytenoid notch. That is the best that you've got. Is there anything else you can do to maybe make that view better? Something we haven't talked about yet. Yeah. Well, you're close. So I'm talking about moving the trachea, right? It's very mobile. So you heard about burp? Backwards, upward. No? Well, let me be the first to tell you. Burp. Backwards, upwards, rightward pressure. I want to be able to see this in lab. Once you do all the sequencing, and if you're not seeing 100% POGO score, you can go and do backwards. Okay, so you're pushing back, down, upwards, bringing it towards you, rightwards pressure. That's what burp means. And by doing burp, what I like about this, notice the laryngoscopist's hand is on the external larynx area. This is external laryngeal manipulation. They're doing bimanual manipulation to make the view as optimal as possible. So what I hate about this picture is that the paramedic should not have the tube in the right hand when the blade's not even in yet. Okay? It should be free to do ELM to optimize the view. This is a much better example of what I want to see. Right? Your right hand is empty, available to do external laryngeal manipulation, like burp. So this is the exact same patient, but now look how much better you see. This is their hand doing some burp. Same patient with burp. Without burp, with burp. Okay? Speaking about cricoid pressure, I'll tell you that we don't teach that anymore. Cricoid pressure has been shown to be kind of ritual more than an effective measure, and it may actually endanger some lives. So in this journal, Anesthesiology, back in 2018, just like pretty much officially died. Burp is more than cricoid pressure, because cricoid pressure is just pushing straight down, right? But that can actually worsen your view. But a little bit of backwards and then upward and then rightward manipulation, that actually makes it better. Okay, so we're teaching that instead of just plain old cricoid pressure. All right, we've been talking forever. We, again, still haven't put the tube in. Can we put the tube in? Well, almost. It is noon. Oh boy. Go a little bit more? You want to break it like 12:15-ish maybe? Okay, that good for you? All right, let's get through this part. The shape of the tube. I see medics still shaping their tube like a horseshoe like this, because what they like to do, or they think they're doing, is they lift, they see the glottic open, and they like curve that sucker in. Okay, you might know people that still do that. I think of that kind of like that Brad Pitt movie where he shoots people around corners, like by going poof, right? Have you seen that silly movie where they curve the bullet? It's the dumbest thing I've ever seen. But anyway, yeah, that doesn't work either for here. It doesn't make any sense because remember we talked about direct laryngoscopy being looking like you're looking down a paper towel roll at a target the size of a quarter. Well, if you look at surgical instruments that are designed to go down tubes, are any of them shaped like a horseshoe? They're all straight. McGill forceps, straight. Alligator clamps, snips, whatever, what do you call these? I can't remember. Anyway, they're straight, okay? This is made to like get things out of ears and noses. They're straight, they're not curved like a horseshoe. And when you think about what we're doing, we're looking down a little tube trying to hit a target the size of a quarter. I would much rather use a straight instrument rather than a curved instrument like a horseshoe, because I'm only trying to get that down the tube instead of getting that down the tube. Make sense? So you don't want to obscure your line of sight with the tube either. Once it's straight, people will sometimes go right down the middle of their sight line, and that's not, you're just blinding yourself, okay? If you go down the paraglossal space like that top picture, as soon as you get to the glottic opening, if you have that little curve at the end of your tube, it's straight to the cuff and you put a little 20-degree hockey stick kind of curve in it, all you do is drop your wrist and it'll go straight through the goalpost. Score. right through the vocal cords, okay? And that's the beauty of it. All you're doing is dropping your wrist, and that curve at the end of your tube will go dive right through the vocal cords. So it's a lot easier to get down that paper towel roll and hit that quarter with the straight to cuff tube than it is a horseshoe-shaped endotracheal tube. This is a bird's eye view. Notice we're not going down the middle. We're going down the paraglossal, the right side, and what the intubator is doing is waiting until that tube tip is right at the glottic opening and then just dropping his wrist and it goes right through there. You gotta know your landmarks, and my friends, this is the part where I hope I can convince you that it's way better to do that stepwise sequence when you're intubating than it is to just hope that you see cords. And here's why, because how many of you have been on scenes where you're the intubator and someone's behind you saying, what do you see? What do you see? You got a tube yet? You want help? You want me to help? Okay. You're like, shut up already. I'm getting this tube, right? Sats are down to 93, 92, 91. It's like not like you can't hear it, right? You're like, shut up already. Can I convince you that if you're one of those medics and like sats are dropping, in fact, and people are like, do you get the tube yet? You've got 18 people watching you in this living room, and you see that you would be tempted to put it in there. I would be. If I'm under pressure like that, heck, I can tell you right now, as an intern, I did that. I saw that, I was like, wow, that's a gigantic trachea. Everyone's like, my attending physician's like, do you have it yet? Do you need help? Like, do you need me to step in? And the most embarrassing thing is get hip checked by your boss, and then they do it, right? So I got this, and I put it in there. But this is before I learned how to do this stepwise sequencing, right? That looks like an inviting target. But in fact, what is that? What's above it now? Yeah, I can now see an interarytenoid notch. I can now see landmarks. I'm like, oh no, that is actually not the trachea, okay? That's the trachea, okay? This looks inviting if you're not thinking, okay? But now you're like, oh, there's two tubes there, and that's the tube I'm looking for. That has some structure. That has interarytenoid notch, arytenoids, interarytenoid notch, glottic opening, vocal cords, okay, and that's what I want, okay? But you'll never know that unless you're thinking about that and doing a stepwise approach. So that was actually the esophagus you're looking at, okay? So know your landmarks, know each series of steps. Here at SCCAD, we have the McGraths as our video laryngoscope. It's a great tool. Notice that it is standard geometry. It is not hyperangulated. So you would employ your normal steps. Even with video McGrath, I would look at lips, teeth, tongue, dangly thing, epiglottis, do all your things. But now, it's just using a video instead, but you need to do your landmarks still, same way, okay? Now with this, you do have binocular vision because you're looking at a screen. You're not looking down a tube, you're looking at a TV screen. So you're gonna be both eyes open, binocular vision. You've got multiple eyes in the room to assist you. You can point, there's the epiglottis, there's the ligament, go there, they can help you, which is fine, okay? What if you have problems with your bougie? This is one of the troubleshooting things, and you're having a little bit of trouble getting the bougie to advance. Have you ever had trouble with getting the bougie to advance?
Where's your brother at?
I don't know, I texted him.
Oh my goodness.
So we're going to introduce the laryngoscope into the mouth, just like normal, and trying to find epiglottis. And you're trying to get the best view of the glottis you can find. But even if you just find epiglottis, you will be able to intubate this patient. That's a Cormack-Lehane grade 3 view. Once you find epiglottis, what you're going to do is you're just going to ride the epiglottis with your bougie. So you're just going along the underside of the epiglottis with your bougie. And if you're doing that, you will enter glottis, and you will be in the trachea. And that's the key. Now, how do you know you're in? Well, there's two ways that are described. The first one is you could actually feel the tracheal rings, and you'll feel the tip of that bougie, that coude tip, rubbing against the tracheal rings. For me, sometimes I feel it, sometimes I don't. What I keep doing is I keep pushing the bougie forward very gently, and eventually, if you're in the tracheobronchial tree, you'll get hold up. Either you'll hit the carina or one of the branches of the main stem bronchi, and the bougie won't go any further. It'll stop at about 40 centimeters. If you're in the esophagus, on the other hand, it'll keep going. You could place that thing all the way to its hilt. So that's how you know. And once you've confirmed by hold up that point of the bougie stopping, you just withdraw until you're at about 25, and then you'll put the tube onto the bougie. Now for this, you really want a partner. It's really tough to do yourself because one of the key mistakes that's made is taking the laryngoscope out of the mouth. You want to leave the laryngoscope in the mouth to keep those posterior pharyngeal structures from collapsing on your bougie. So you have an assistant place the tube over the bougie, hold the top of the bougie, and this now allows you to advance the endotracheal tube through the cords. Just given the shape of the endotracheal tube, oftentimes it'll hold up on some of the cartilage, or it'll just get caught on the cords. What you want to do is just rotate the tube counterclockwise 90 degrees, and then gently go back and forth and rotate ever so slightly, and eventually tube will pass. As long as you're gentle, you're not going to cause any airway trauma. If you try to jam this thing in, that's when you run into problems. So eventually the tube will start passing. You go into about 22 or 23, take out your laryngoscope, you take out your bougie, and you confirm your endotracheal tube.
Okay. Another way to remember that is something called bougie left turn, BLT, like bacon, lettuce, tomato. Bougie left turn, if your bougie gets hung up on something, then giving it a counterclockwise turn from like noon to 9 o'clock, or a left turn, bougie left turn, is a good way to kind of get it unhung up from your tracheal rings. All right. Once placement is done, so now we talked about placement. Next is going to be proofing. Once you've got it placed, you want to make sure that you prove it's in there. You know, the ways you do that is, remember CAT-P, capnography, assess, tube holder, and placement of the teeth recorded, okay? So capnography is the gold standard. So it is malpractice not to use capnography. Once you place it, you got to prove it with capnography. You still want to assess for bilateral breath sounds, because even if you are placed in the trachea, guess what? You might right main stem them. Then you would expect to hear no breath sounds, or very little in the left, but lots in the right. Then you can pull back just a little bit. Make sure you get a commercial tube holder and secure it properly, and then reassess, and then record that placement of the teeth. A good rule of thumb is 3 times the ETT size is about where it should be at the teeth. So if you're putting a 7.5 in, times 3, you should be at about 22, 23 centimeters of teeth. Okay, so an 8 be about 24, things like that. And then post-intubation management we'll talk about next week. Okay, really quick, a vocabulary check. You've heard the term difficult airway a lot, but you'll also hear people say failed airway and crash airway. And words mean things. I want you to know the differences among those 3 terms. So a difficult airway is an airway that poses certain challenges, that requires the requisite KSAs, knowledge, skills, and abilities to overcome those things. And that's what we've talked about. We talked about the 7 Ps, we talked about racer, lemon, all these things to overcome a difficult airway. But then there's failed airway, and failed airway is something that, it doesn't mean you failed. It means that the airway itself has failed. Sometimes factors beyond your control can contribute to an unsecured airway, or no tube in the trachea, like maybe excessive blood, vomit secretions, head or facial injuries. You have to meet at least one of 2 criteria for it to be called a failed airway. Number 1, 3 attempts, still can't get the airway, with no hypoxia, so you're still at 99%, great. Or you've done 2 attempts and now your stats are dropping. Okay, so that's considered a failed airway. But the term is going out of favor because you don't just stop at this point, right? If you've got 3 attempts and you can't, but they're not hypoxic, you're not just going to stop getting an airway, or vice versa. You have to progress down your rescue airway algorithm. So the immediacy of your actions in a failed airway is really dictated by whether you've got hypoxia or not, right? Because can I convince you that if you're not hypoxic, you've got a little bit more time to plan, right? Put your tools down, take a deep breath, gather your team, say, okay, what haven't we tried yet? What can we do differently? If they are hypoxic, then restoring oxygenation is the prime goal. So do a rescue airway, put the eye gel in, or BVM with PEEP plus a true high flow, or at least 15 liters nasal cannula, right? True high flow, more than 20 liters, right? These are things you can do. Restoring oxygenation is your prime goal, not necessarily plastic in the trachea. If they're not hypoxic, breathe the box while restarting your pre-oxygenation phase. Go back up to your pre-ox phase in the 7 Ps and restart all over again. What do I mean by breathe the box? What does breathe the box mean? Anybody hear about that? Fighter pilots do it. NFL players do it. Yeah. Yes, exactly. It's basically controlling your adrenaline surge, your sympathetic nervous system, right? So breathe the box. Breathe in, slow, 4 seconds, hold 4 seconds, Valsalva a little bit, slowly exhale for 4 seconds, and then hold that for 4 seconds. And you do that a couple, 3 times, and that really does reduce your systolic blood pressure, reduce your heart rate. It's good because the less jittery you are, the better you can think, the better you can control the situation, okay? So a failed airway, not hypoxic, you've got to be able to change something. You have time. Okay, change clinicians. Say, have your partner try it. Have your BC try it. Something. Change your bougie. Change your Ducanto method. If you're using method 1, use method 2 or vice versa. Change tube side. Change your external laryngeal manipulation. Something to try to get this airway, okay? But they're not hypoxic, so you have a little bit of leeway, okay, to do this. Whatever you do, don't be hyper-focused. We don't have time, but basically this clip is, remember from Top Gun, the original one, where they're so focused on the bogey that they are unable to focus on, they lose sight of the MiG that's behind them, okay? They miss the gorilla. You ever seen that video where they're so focused on the basketball players, they miss the gorilla walking in the middle of them, okay? What happens when you get so focused on your airways that you don't see that they're hypoxic, you don't see that something else bad is going on, so you need to involve your partners and involve your team. And then finally, a crash airway. This is defined as an airway that is either eventually unobtainable or immediately obviously unobtainable. If it's eventually unobtainable, then your failed airway algorithm has been exhausted, but the airway is still not secured. The IOU, or the immediately obviously unobtainable airway, is the one that's a crash airway that you need to do something, okay? So this is rapidly progressing. They are not going to survive if you don't do something. This is your crash, and crash airways are treated with a crike, okay? So IOU, just think IOU, a surgical crike. If it's immediately, obviously unobtainable, that's what you need to do. Cannot intubate, cannot oxygenate, cannot ventilate is crike. Next week, we will talk about that with surgical airways, all right? Okay, thank you very much for letting me go past 12 o'clock. We are now at the noon hour. When you come back at around 1 o'clock, we will start moving into, we'll have our live demo of the 7Ps. We'll do a quick review of that. And then it's really, really helpful to see it actually done, because that's what you're going to do in lab next week a lot in preparation for your exam. And then we'll talk a little bit about airway pharmacology. Hopefully we'll get done for that by 5 o'clock and you can enjoy your holiday, hopefully if you're on your 4-day. If not, be safe. All right, be back in about 44 minutes and 11 seconds. Okay. All right, welcome back. I know we have covered a ton of information, but you're almost done with this day. You doing okay? All right. Before our live demo, we're going to talk a little bit more in depth about just the process of RSI itself. I know we talked about some of the physiology of it and how, but now we're going to go into a little bit more detail. RSI versus DSI. Remember how I said that really what separates EMTs from paramedics is knowledge. What separates paramedics from critical care paramedics is the why. And so when and when not to especially. So let's talk about it a little bit more. Rapid sequence versus delayed sequence induction. Has anyone heard of delayed sequence induction before? It's a fairly, not new concept, but one that we're just starting to pay a little bit more attention to for certain patients. Remember that RSI assumes the use of a paralytic immediately given after the sedative. Remember, we said that this morning? Delayed sequence induction is where you give a sedative first with or without a paralytic. And if you do give a paralytic, it's not immediately after. Why would you delay it? Well, as we mentioned earlier this morning, in your pre-medication phase, before you push any meds, if you determine that this patient has some H-bombs that need to be corrected first, some physiologic parameters to avoid a post-RSI crash that you need to bolster up first, then delayed sequence induction might be right for that patient. So RSI will be used the vast majority of the time, but there are 3 things especially. where you cannot, really should not, give the paralytic immediately. That is refractory hypoxemia, which we said was the first of the H-bombs, right? You don't want to push RSI meds when their sats are 80%. Good grief. That's a clean kill, right? You want to try to get their O2 sats up to 100% if you can first. The other one is severe hypotension. Again, can you optimize their hemodynamic status? Can you get their pressure up from 80 to at least 100, 110 higher before you give them a sedative and a paralytic? And then third, metabolic acidosis. So that's the other H, hydrogen excess, a hydrogen ion excess, right? Acid. This is not good. So delayed sequence induction buys time. Some patients are so unstable or they're so altered that they're combative that the only way to optimize them is to sedate them a little bit. Now, what's the problem though with sedating someone who is hemodynamic unstable? What do most sedatives do? Make it better or worse? What's one sedative that can actually maybe even support it, make it better? Ketamine. So probably the most common DSI sedative is ketamine, and that's why. Much more stable from a hemodynamic standpoint, may in fact help increase the blood pressure a little bit, certainly not decrease it like say Versed would do, or propofol, right? So you settle the patient down. It allows you to do your medical interventions and bolster them up so that they don't crash after RSI. It buys you some time if you utilize a paralytic, and you may not, but if you do, it's well after resuscitation. So you resuscitate them first. Then, if you need to, you can give them a paralytic. So there's nothing rapid about it. So it's not sequential, it's not rapid, it's delayed. So that's why it's delayed. What are the contraindications to delayed induction, however? Well, obviously, if they're not breathing. No bueno. Wherever, it is what it is, you gotta get their airway, okay? If they are an immediate aspiration risk, like they are actively vomiting on you with a GCS of 3, like you can't wait, right? Get your Ducantho in there, try to clean them out as much as possible so they don't aspirate it, but you can't then wait 10 more minutes. You don't have 10 minutes. You gotta secure that airway. And if they can't tolerate ketamine, maybe they already have severe hypertension. Maybe this is actually a hypertensive bleed. Maybe this is someone with high ICP already. Maybe this is someone that's already under the influence of some other hallucinogen or PCP. Well, then they're not really a good candidate for that. The quick differences between the two then, RSI and DSI, really is the very first step. You notice the primary difference is that unlike RSI, where you pre-oxygenate first, that moves to second place. It switched places with the sedative. So that really is the primary difference. The other one being, of course, the paralytic, whether you use it or not. But really the main one is you're switching paralytic and sedative. So flip-flopping them in DSI versus RSI. So here's the biggest peril though. Once your thumb pushes the plunger on your paralytic, if you use it, only two things can happen. You get an airway or they die. Well, that's just great. But hey, no one's forcing you to be a critical care paramedic. Remember, you wanted this, okay? So bringing it all together, remembering the why of everything we've discussed thus far, preparation, positioning, pre-oxygenation, pre-medication, paralysis, place and proof, and then finally post-intubation management. This is what we're going to kind of go over now, okay? Remember, preparation. What is the first P for? To select the right patient. If we think they're going to be a difficult airway and they'd be hard to oxygenate when you paralyze them, well then consider DSI without a paralytic, or just manage them non-invasively if you can. Because remember, this part of preparation was prepare for the race. So racer is the R in racer is recon. The last R is recon. So you want to look and see if they're not a good candidate at all. Then if you can support their oxygenation just bagging them the whole way or with a supraglottic, then great, do that. Okay, the better part of valor is to keep their oxygenation up and not let them go hypoxic. Okay. Then the second P, positioning, remember, was for what? Optimize your chances for first pass success. Why? Because after 2 or 3 attempts, what do we know about statistically what happens? Tenfold increase in cardiac arrest, mortality, death, okay? So create the best physical conditions for getting that airway in your second P. Pre-oxygenation, you're buying time. With a nitrogen washout, oxygenation, you're moving the needle as far to the right on PaO2 from 80 to 100 to 300 to 600 if you can, because the farther you can push that PaO2, the longer your safe apnea time is going to be. Even though their pulse ox may be identical, maybe 96% or 97 even, right? You have no idea which one's at 600, which one's at 85 or 90. They're both at 96%.
600 the highest you can go up for PA?
It might be able to go higher, but I don't know if it measures any much higher than that. I don't know. What's the highest PaO2 you've seen on an ABG? The highest I've seen is in the hundreds because they were on O2 for a long time. But
I don't think I've ever seen one that's like eye-popping or anything.
I don't think I've ever seen like 1,000 or something like that.
It's
But
fairly temporary too, like, you have to like put forth effort to keep it really high.
yes,
Like,
exactly.
once you're not pumping a bunch of oxygen in there, it has a tendency to level out.
What's the, like, why would you need someone's PaO2 to be that high? I mean, if normal range is 80 to
Well,
100.
you wouldn't want to. You wouldn't want to leave it that high. In fact, remember, hyperoxia is a bad thing as well. I'm only talking about for purposes of pushing someone that far to create safe apnea time temporarily. I'm all for it. I am all for it. But in the ICU, if someone's PA2 comes back in the hundreds, we turn the FiO2 way down. We say, whoa, this is bad, because hyperoxia is bad. So we just want them to be 100, 120-ish. That's perfect, right? But we don't want them to be at 600 all the time. What's one of the most stunning examples in medicine where oxygen was first found to be harmful? Neonatal ICUs, remember that? What happened in neonatal ICUs back in the 60s, 50s? These babies went blind, remember? Because they put them on these isolates, 100% oxygen, and then these babies started to go blind because it was toxic to the optic nerve cells, yeah. And then, of course, pre-medication, anticipate and counteract the post-RSI crash. Fix your hemodynamic compromise, fix your hypotension, fix your hypoxia, fix all these things first before you push the meds, avoiding that post-RSI crash. So stop and think, stop and think, stop and think. When you get a scenario, which we're about to do and demonstrate, stop and think each step. That's the whole point of this. It's the cognitive function. This is a cognitive forcing strategy. Think about the 7 Ps as a cognitive forcing strategy. What does that mean? It means it forces you to go down the list of what are the most important objectives and goals before you push meds on this person, before you attempt intubation of somebody, okay? The induction agents that you have to choose from, which we'll go in great detail in a little bit this afternoon, are gonna be ketamine, etomidate, propofol, Versed, and of course your neuromuscular blockade agents, ROC and SUX, the 2 most common ones that you're gonna use. At this time, I would like to invite Mr. Bowers, Chief Stewart, to come up, because we have found in the past, especially last year, that all of this can be really overwhelming to a class at first, because we just threw an encyclopedia of knowledge. You know, that would be a really, that'd be an interesting class. But what we have found is that talking about the 7 Ps is very different from actually seeing the 7 Ps. I want you to pay close attention to how they do it, because how these 2 demonstrate the 7 Ps is pretty much what they're going to expect to see in your test, July 25. So it would pay to pay close attention to how this is done. What I'm going to do is I'm going to talk about each phase and just basically narrate, and then they're going to talk about how they're mitigating each thing on the board. So remember our 7 Ps. Number 1 P is going to be preparation, and remember, we prepare for the race. And so, Chief, what's our scenario?
So it looks like we've had a 78-year-old male patient that we're responding to at the base level of consciousness. Due to the symptomology and the history of previous complaint, we determined the patient's probably having a stroke. The patient is not orientated to any way, he's drooling. He's got loss of function on one side versus the other.
Put the people on the video.
So we're going to assume he's got a stroke of some kind. We don't know what kind. but he's got no airway control on his own. Vital signs are on the board for you. He's got no gag reflex. Okay. He is 5'8". He weighs 182 pounds, which is 83 kilos.
So, knowing that, remember we talked about indications, right, and contraindications. What are the indications? Why would we decide to intubate?
His level of consciousness is decreased and his SpO2 is.
Dr. Tan, you should have this because you're still narrating.
His,
Listening.
Yeah, when you start talking, I'll just walk over.
Oh.
and his respirations are starting to.
Yes, so indications. For those of you on the video, we talked about, earlier this morning, we talked about indications, contraindications. Why would we intubate somebody? Well, we know that they're hypoxic. We know that they have a severe altered level of consciousness, presumably from a stroke of some kind. They have no gag reflex. So a couple of things. We talked about imminent risk of losing an airway or imminent risk of aspiration. So if they can't control their airway, they have no gag reflex, they are wide open for aspiration, right? And we know that that's really bad. We know that they're hypoxic. So, but remember, we also said that it is refractory hypoxemia that is the problem, all right? So if we can do anything to help that, we will, but we're getting a little bit ahead of ourselves. First, we're making the decision to intubate. We know that end tidal is a little bit high, so they're not ventilating. So they have both ends of the problem. They're not oxygenating, and they're not ventilating very well either. So they're at about 83 kilos. We have made the decision that we need to take this person's airway. So the first P is prep. What is this team going to be doing to prepare? What acronym are they using? RACER, okay? So, crew, do you have enough resources? Do you have all the help you need? Do you have all your equipment?
Yep.
You have your oxygen and suctioning? Okay,
All
so,
we need is Nate. I'm just here to look good.
all right. So Nate's doing all the work. Chief Stewart's looking good. He got the resources. A is access. What kind of access do we have?
We have a large bore IV and the biggest vein I could find, which is an AC on the left side.
An 18 in the left AC. They have an IO just in case. 2 sites are recommended so they can start a second line or have an IO as well. C is capnography. They were already on capno. That's how we knew that the end tidal was 55. So capnography is there. Why else do we need capnography? To rest, because at the P number 6, when we're placing and proofing, it's malpractice not to have capnography, right? So good. So that's already in place for both. E is emergency backup plans. So crew, what are the emergency backup plans that you have?
Currently, I have a blind insertion airway device, and ideally, I would also have my surgical kit as well, ready to go.
So he's got a rescue device in the form of an iGel. He's got a surgical crike ready to go as well. And plan D was D for different. So he's got different blades, he's got different adjuncts, he's got different stylets. So he's got a plan B, C, and D. Good. And then R, they are going to recon for a difficult airway. Now remember, we talked about another acronym to help recon for difficult airway. What was that? Lemon. What does the first L mean? What are they looking for in L? L was look externally, right? So what are they looking for?
Any like abnormalities, facial trauma that might.
Right. So looking for obvious obstructions, swelling, hematomas, structural abnormalities, facial hair that might prevent good oxygenation, small jaw, right? They're looking also for E. What's E? 332, right? So looking, what's the first 3? Right. So he's checking with 3 and checking to make sure that he had at least 3 fingers for opening. What's the other 3? Good. Thyromental distance.
So he's a 2.
So he's already, there's a problem, right? There's a 2. So how about the other 2? Thyrohyoid distance, right? Okay, so that's 2.
He's a 1.
So instead of 332, this patient is a 321, which is not optimal, right? So at least it's a 3, but it's a 2 and a 1 for the other scores, which is like, well, so now the laryngoscopist understands we might have an issue with the blade or anterior airways. So that will make the E in RACER that much more important. That'll make sure he's already making sure he's got his SGA out, his surgical crike ready to go, other adjuncts ready to go. Very good. And then M is Malampati. So he's going to look at that. O is obstructions. Any other obvious obstructions? What else is O? Good. Blood, vomit, secretions. And then the tongue, and then N, neck mobility. So, okay, he's checked. The neck mobility is great. Now he has a C-spine injury, but that's okay.
Live over limb, brother.
Live over limb. All right, very good. So he's gone through RACER, and he has optimized the first P of preparation. Okay, so good. So what's the next thing he's going to do? Positioning. Why is positioning important? It is the primary determinant of what? First pass success. Okay, so good. So what did we say is the preferred way to position the patient? Ramping or sniffing? Ramping. If possible, ramping is better. We can get the torso about 20 degrees up and the ear and sternal notch lined up. That's perfect. Should the face be facing forward, backwards, or parallel to the ceiling? The face should be parallel to the ceiling, if at all possible. So let's see them ramp that patient and optimize their positioning.
So I teach positioning a little differently than that. Can I show them? Or?
Yes.
Okay.
You use the blankets.
You go a little more. This is just a tiny more. Okay, so there are 3 components to positioning, guys. Padding, sniffing, and ramping. Now, Dr. Tan considers ramping the most important. That's fine, we'll go along with it. But,
I'm only a doctor.
no, sometimes, whatever.
Whatever. I get no respect.
No, not in this place. Okay, so hey, listen, let's worry about padding first. And padding means what? We've got to put him on an incline to get naturally positioned, right? We could ramp him, but what's ramping going to do if you start there? It's going to pull the airway structures down, it's going to move the head forward. And that's going to minimize the area you have to operate with the laryngoscope. So I would like to see where we pad him first. And so I'm going to lift up the patient a little bit, and Nate's going to start a little bit under the shoulders, and then gradually move it, the incline up and up and up. So just one thing on the shoulders. There you go. And then gradually incline it up and up and up. And see what we're doing? We're creating an incline like this. And once we get up there, and the further we get, see what's happening to the head? It's moving up, and now we've got good ear to sternal notch alignment, but we're not moving the head down like this and closing our third way. So we're short on blankets, but let's just double them up here. Okay, see that? That's a good pattern. Start here. And now what's sniffing? Sniffing is make sure the face is parallel to the ceiling. So now when I do that, what happens to the neck when I do that? It's exposed all that. That's good for 2 things. 1, because once I get that blade in there, I've got a really good view of those cords, trust me. And 2, if I need to go to crash airway and perform a crike, everything's already exposed for me. I'm in a proper position to be able to get to that neck and look at the anatomy and get it taken care of. So let's pad them, let's sniff them, and then finally, let's ramp them. So if you need to ramp them, you can, but look what's happening to the neck. Is it going forward like this when I ramp them? It's not. It's staying in really good position, and now I'm in an optimal position to intubate. Remember, there are 3 airway accesses we're worried about. We're looking about the oral access, the laryngeal access, and the pharyngeal access and the laryngeal access. Remember, the vocal cords are down here, right? So if all these 3 accesses can meet at this juncture here, then that's exactly what I want. And so we're going to practice in the skill stations tomorrow or next week. We're going to practice intubating with no padding and ramping and sniffing. And they're going to pad and sniff them, and you're going to intubate, and you're going to see a world of difference between the 2. A world of difference. So now my patient's positioned appropriately.
And if you happen to be available for the cadaver lab in August, you'll see this on real cadavers. We do the same thing. We don't position them. And then especially when we have larger cadaver specimens, and it's a night and day difference when you actually optimize their position. Then it's like easy day, okay? Now, in my defense, I think whether you ramp them using the stretcher or ramp them with blankets or a troop elevation pillow even, which is a wedge pillow, the point is you are lifting the torso, you're not leaving the torso flat. I like this as well. Maybe this way you do have a little bit more control, finer control over the head, but this is really, really nice. And since he's going to be grading you on the test, you better do it this way.
Yeah.
So very nice.
I really outrank the doc. I write the test.
But see how nice, with just a little bit of finesse, you get the ear, the external acoustic meatus, and the sternal notch so perfectly aligned. That's That's really elegant. So hopefully you'll be able to do this on the ambulance as well, using pillows, blankets, towels, whatever you need to do. What we have also found is that a full box of gloves is actually the perfect height that you can put underneath there as well to help elevate the occiput off the bed.
And a
So-
pinch, 4 to 6 inches of elevation is all you really need. If I measured that, that's probably 4 to 6 inches.
Yep. Okay, good. So he has ideally ramped and positioned the patient and has aligned the 3 axes optimally. Notice he's not hyperextending or hyperflexing. The face is parallel to the ceiling and it's perfectly positioned now and perfectly aligned. Next, P is pre-oxygenation. How are you going to do that?
Well, we're going to start off pre-oxygenation, always, always, always. Everybody say always. Always. By placing a cannula in the patient's nose. It doesn't matter what cannula you use. We started with the entitled cannula, so keep it on. We're going to put that at what liter flow? 10. 6. No more than 6 for this particular cannula. If I want to take that off and put on a normal nasal cannula, I can. And what's my liter flow in here? 15. Okay. Just get out of 10. 10 doesn't work for anything. All right. So either one. And did Dr. Tan talk about the minimum liter flow for what is it? What's the minimum number we're looking for liter flow for pre-oxygenation? 20. Can we?
The cutoff is 20. Anything more than 20 is high, anything less is considered low.
Okay, is there any one device that we have that provides 20 liters of flow? No, except for ventilator. So that means we have to use how many devices for pre-oxygenation? Always 2. So I can go with this cannula or go with this cannula. This I'm going to set at 6, then this I'm going to set at 15. And then we determine, 1, is my patient breathing on their own adequately or not? Is my patient breathing on their own adequately or not? Well, they're breathing 10 times a minute. They have an SpO2 that's low. They do have an entitled that's functioning. What are my 3 choices for pre-oxygenation? There's only 3. What are they? Okay, 1 is the ventilator for sure. And we'll teach you how to do that when we get to ventilator class. The other 2 is cannula and a non-breather. The other one's cannula and a BVM. So which one should we use for this patient? Which method? Forget about the vent. Cannula and a breather. So that's fine as long as he can move air. And how many liters am I putting this on? So what's my total liter flow? For this patient, 21. I'm over 20. Another benefit of putting this on immediately is you don't have to do it later when you're ready to intubate for the no DSAP procedure. It's already on and running. So just intubate through the process, right? So we're going to pre-oxygenate with 21 liters of flow, and we're looking for an SpO2 of above 94 and above. Now, when do we start the 3-minute timer? Whenever you reach the highest you can get in the shortest amount of time. So give it 30, 60 seconds, whatever that number that is, you start the timer from there. So is intubation a slow or a quick process? It's a slow process, that's why.
What if you're like at 96 and like you wait 3 minutes and all of a sudden it drops to 97? Do you want to
Great.
restart or?
Great.
I mean, if it's been like right at the end of 3 minutes goes to 97%, I don't necessarily expect you to wait another 3 minutes. However, if you also recall from the lecture, we said if you have the time, then so be it. If it takes more than 3 minutes, remember we said so be it. If it takes 6 minutes, you just bought yourself another however many minutes. To your point, Miguel, it's like, well, maybe you bought an extra 45 seconds, maybe you bought an extra 3 minutes. Who knows? But you bought more. So if you have the luxury of, hey, you know what, we're good right now. They're not vomiting. We're moving in the right direction. It just bumped up 97. Let's give another minute or 2. Fine. That's your discretion. Yep.
We could use the BVM, right? So Nate will talk about using the BVM and what we need to do with that.
Sure. So the advantage that we give the BVM, obviously, is we can assist ventilation. So like, let's say that it is 10, but it's 10 shallow. Okay, we can add in a little bit of extra pressure support on top of that. Also, the big advantage to the BVM and also the ventilator is PEEP. Okay, I'm sure Brian will touch on it, but like we want high flows, high FiO2s, and high PEEPs. PEEPs is the third part of that. Okay, FiO2 is something that we won't necessarily be able to directly control with just these more simple airway adjuncts and devices. That's really something that when we get into the ventilator. But yeah, so the big advantage there would be we get PEEP, provided that we have a good seal. We have the luxury of, well, most of us anyway, working at St. Charles County Ambulance District. So anytime that we're going to be in a scenario like this, we're going to have a whole bunch of people, right? So we're going to be able to have somebody who is the dedicated airway person who's going to be able to hold that good seal and provide us some extra PEEP. Okay. Also, if we have a patient who is, so this patient is both hypoxic and hypercapnic, and like Dr. Tan was talking about, if their altered mental status is due to a hypoxia or a hypercapnia, this device, and way more efficiently the ventilator, will fix both of those things, and maybe we won't have to drop a tube, right? So.
Yep. And remember, in big red numbers on your handout, we said 93% was a predictor of desaturation, which is why the answer was 94% or above. That's our goal, so that we can avoid that precipitous fall if at all possible. Okay.
When I use this BVM, what is this reservoir bag doing with everything? If it's hooked up to high flow O2 right now, what's my reservoir bag doing as I'm pushing this right here? What's this bag doing? It's inflating and deflating, isn't it? Because the oxygen that's going into the patient is not coming from this bulb. It's coming from in here, right? So if I put this on a patient that's spontaneously breathing and my bag's not inflating and deflating, what's happening? I'm not oxygenating. He's getting air, but it's being pulled in from the valve here. So what's the problem? What's not happening? Air movement. Why? Because there's a one-way valve here. The patient's inspiratory effort is not strong enough to overcome the one-way valve, so they're not getting oxygenated. So you cannot use a BVM on a spontaneously breathing patient to oxygenate them if you're not pushing the bag, because they've got to overcome. Now, if they're breathing deep enough and strong enough to overcome the valve, they can use this, but you'll see evidence of that with this reservoir bag opening and closing. Everybody understand that? Okay.
Can I add one small thing?
Please do.
Preparation phase. So one thing in the preparation that we kind of glossed over it when we talk about our resources and having all the people that you need. There is one person that you need to designate that's very important, okay? The person that you're going to designate is the person who is going to be ideally in charge of your pre-oxygenation, okay? So they're either going to be operating the ventilator or they're going to be squeezing this bag, or if they don't have to be squeezing this bag, they're the person who's going to be like at the head of the stretcher while you're preparing your stuff. Because the next job that they have is they're the person that's going to be watching your SpO2 for you, okay? They're the only person that's allowed to speak, like while you're going through your intubation attempt, okay? Everybody else, the room is silent, and then all they do is tell you, they just give you, like if Miguel is, they'll be like, okay, Miguel, we're at 97%. If I lose a percentage, I'm okay, 96%. I'm not like, you know, like, hey, hurry up. It's just informational, just like, okay, this is sort of what we're doing. But the other big job that person has that they need to be prepared for is if you have to pull back, if you have to you know, be the Iceman to get out of the way of Maverick, they're your Maverick, okay? That's the person you've designated to, if I can't do this, if for whatever reason something goes wrong and this doesn't do it, when we reattempt, they're the person who's gonna reattempt, okay? So just designate, like, give out jobs, all right? So don't just like, okay, I have everybody I need. It's like, make sure, like, Brian, you're my number 2. You're gonna be in charge of pre-oxing. You're watching the monitor for me. And if I don't get it, you're up, okay? That way they can mentally prepare and they can understand everything that you need to understand, okay?
So now we have done everything we possibly can to optimize oxygenation and pre-oxygenate them, try to increase our safe apnea time as much as possible. And now we are ready to make the decision, basically, before we push the medications, meaning pre-medicines. Another thing that I was thinking about changing this P2 was ponder. You know, because now you're pondering, am I ready to push the meds? Well, remember we talked about our H-bombs. What about our hemodynamic compromise? Hypoxia, hyper or hypovolemia, dysrhythmias, hyper-K, pain. Do we need to do anything to increase or optimize our hemodynamic status before we push the meds? So things like fluid resuscitation first, or oxygenation, which hopefully we've been addressing in the pre-oxygenation phase. So when you look at our current scenario, what are the H-bombs that they are going to need to address before they push medicines? She is hypotensive, right? Pressure is 82/60. What's another thing? The hypoxia. She was at 80%. So let's say that after all of this pre-oxygenation phase that we just did, she's up to 96%. That's good, right? That's one H they've addressed. How about hypovolemia? We have not addressed that yet. What are we going to do to address that? What would you like to do for that?
I'd like to administer fluids.
So we have 2 lines. We're going to give some crystalloid at first and see if that helps at all. Because we checked the blood sugar already. We can give some fluids. At what point in time would you be happy with the blood pressure?
So I'm going to start off with a fluid bolus about 500 cc's. unless it's a cardiogenic issue. And we'll talk more about that when we get to shock. If I don't see response within 500 cc's, I can repeat the 500 cc's, but I'm really looking toward vasoactive medications to help me get through this short-term problem. Hopefully it is a short-term problem. That brings up a good question though. We have to get 500 cc's. If we just drip that in, how long does it take to get in? A long time. So what's ways we can give a fluid bolus that's a lot quicker? There are 3 ways we could do it. Pressure bag is one, good. Push, pull is another. We'll practice that next week. And then thirdly is the infusion pump. So if you're going to do a bolus, those are your only 3 options. Dripping medication in is not a bolus.
Bolus means bolus, rapidly. So it's not just a drip, drip, drip. Good. So let's say that we give an actual bolus, and after 500 cc's, the pressure is 110 over 75. Is that okay?
I like it.
Certainly better than 80. Okay. So we have optimized our H's as much as we can. Obviously, by this time, they're going to be fully monitored. They'll be in a cardiac monitor, pulse ox, end-tidal CO2. There's no dysrhythmias. There's no SVT or third-degree heart block or anything like that. Oxygenation is better. End-tidal is improving. No need for vasopressors at this time because she has responded at 500 cc's of crystalloid. Cool, right? So now we've gone through our pre-medication phase. We've done everything we can to avoid the post-RSI crash. So what comes next after pre-medication? You can look at your sheet. Good. Paralysis with induction. Okay, so this is where we have decided, for the most part, they're going to do a rapid sequence induction, not a rapid sequence intubation, because the intubation, as we've already mentioned, is not fast. There's nothing rapid about it if you do it correctly. But the induction is, and again, what's the purpose of rapidly inducing a patient with a paralytic? Paralyzed diaphragm, number 1. And then the second reason, optimize conditions. So get rid of the trismus, optimize placement. Good. So you know the patient's weight. What are your doses going to be? Help this crew here. Let's say that you pick, first of all, you're going to pick a sedative. What are you going to push? You have ketamine to choose from, etomidate to choose from.
168, and which would be like 170.
Okay.
How many cc's is that though?
You drop like, if it's in 5 cc's.
It's
So
a,
you- right?
it's a,
505.
no, 10. 500.
510,
Mhm.
okay. So then it's,
Go ahead.
Yeah.
is it 3?
Over 3.
If it's a little bit over 3, can we just round to 3 and be okay?
Yeah.
Absolutely right.
Yeah.
So say 3, say 100, how many milligrams was it?
It was like 170.
170 milligrams and say 3 cc's. Now, when you do your medication cross-check, you need to verbalize that.
Mhm.
I've got 170 milligrams, and I'm going to give 3 cc's. Is that okay? But we'll cover that in a second. Yeah.
And then what do you want to use for your paralytic agent? How many cc's is that going to be? Okay, good.
How many cc's?
Oh, cc's. 83.
Oh, 83 milligrams.
Yeah.
Okay. how
So
many cc's?
it's about 8, right? Good.
So we'll say 8 cc's.
Yeah. Okay, so do you have that all drawn up?
Yep, got it drawn up.
Let's say that's, okay.
I've got ketamine here. It's, how many milligrams? 160 milligrams. I'm going to give it in 3 cc's. Here's my vial, here's my syringe, verify my volume.
Any known hypersensitivity, allergy, or contraindication?
No known allergies, no known contraindications.
Very good. Verified it is 3 cc's and that the vial's right?
Good. Then I've also got rock. It's a given, I'm gonna give 70 milligrams, which is the 7 cc's. Here's 7 cc vial and syringe.
Make sure that I have 7 cc's, no hypersensitivity, allergies, or contraindications?
No.
Okay,
I'm giving both for RSI.
very good.
When provider number 2 is looking to verify the volume, what else are they looking at? In order for volume to mean anything, what does he have to know? Concentration. Because especially ketamine, it comes in various concentrations, depending on shortages and who the manufacturer is. So he's looking at the concentration, making sure that that actually equates to 168 milligrams, and then the cc's make sense, the math-wise. Okay, good. Good, so they have done their medication administration cross-check. They are ready to push the meds.
Okay, I'm going to give, I got a ketamine, a rocuronium, and a flush. I'm going to push the ketamine first, followed immediately by the rocuronium, followed immediately by a flush, and I'm going to wait 30 to 60 seconds to look for any response. The response I'm looking for is sensation of movement and breathing.
You don't have to flush between those meds?
No.
They're compatible?
No, they're compatible. Matter of fact, do not flush between the meds.
After that 30 to 60 seconds, I'm going to confirm that I have paralysis. Whoever I have that's doing my BBMing, they can let me know whether or not they can feel the patient stop breathing, or conversely, if they're on the ventilator, if I had the purple triangles and I no longer have the purple triangles, then I know that my patient is paralyzed.
Suction.
Okay.
I got suction.
Yeah, I didn't have a suction, so we're gonna pretend that this is my decanto suction. All right. I'm gonna perform my laryngoscopy. I'm gonna go in with my suction.
So we're now in the place and proof, right? So he's doing suction, scissors, series. Suction, scissors, series. He's done suction.
I'm gonna place my ET tube. I'm gonna keep my view here. Oops, sorry, Doug. Until I see it cross the cords. I'm gonna have my person who was my SpO2 guy. They're gonna give me make sure that my ETCO2 probe is in place. They're gonna give me one breath over the epigastric. Do I hear epigastric sounds?
No.
All right, I'm gonna do over each lung field. Okay, clear. I can go ahead and I'm gonna use my commercially available tube holding device.
I had it somewhere.
I couldn't find it in the kit.
I had it. Oh, it's right there. Someone threw it on the ground.
Preparation.
It is right.
Fail. Fail. I had it. And now we can remove that cannula from the nose, right? We don't no longer need.
Now, when you do your exam, July 25, I really will expect to see with your suction, scissors, series, your series, we want you to say the sequence of visualization. Watch that blade go in. Lips, teeth, uvula, tongue, epiglotoscopy, where you're putting the blade, engage the hyoepiglottic ligament, look for your landmarks, interretinoid notch, glottic opening, vocal cords, and walk through that whole process. Okay, very good.
So I remember talking to a couple of anesthesiologists whenever I was doing my OR clinicals for intubations, and they said a good way to check for paralysis is to tickle their eyelashes. Is that still a good thing?
I've seen them do that.
Like,
Yeah, they'll flick the eyelashes, and if it twitches at all reflexively, then they're not completely paralyzed.
right.
Yeah, I mean, yeah, you can do that. I can tell you in emergency medicine, we don't do that.
Okay.
We can particularly if we use a depolarizing NMBA like sucks, we can actually see the worms under the skin and the defasciculation going wait another 30 seconds. We know that they're good. If you're using a non-depolarizer like rock, you just have to wait a sufficient amount of time, usually about 30 to 60 seconds, and then just really the easiest way is to watch your end tidal, because it'll go from a 4-phase square wave to flatline, right? Because they're not breathing anymore. So now, then you know that the diaphragm's paralyzed, which is exactly what you want. But yeah, you can do those little things like, sure, it doesn't hurt, you know, it's not like saying we don't do it, but.
Can we redose rocuronium if we need to? Can we give another dose of rocuronium to this patient if we needed to? If after 60 seconds they're still moving? Who says yes? Who says no? Well, guess. Solomon, what do you say? Yes or no? You can. Very good. Absolutely you can.
Yes.
Remember, the therapeutic dose of rocuronium is also the lethal dose of rocuronium. So, I mean, until you get into like these massive doses, do you start having like issues with it? So yeah, like the. Right. So yeah. So it's for our purposes, yes, you can redose rocuronium. You have a very high upward limit for what that is, because you want to do it until they become paralyzed.
Dr. Tan, would it be half dose or full dose if you had to redose?
If I had to give a little bit more rock, remember, how long does rock last?
Like 30-ish minutes?
It's 30 to 45 minutes. So the longer a paralytic lasts, the longer it takes to fully take onset as well. The reason why succinylcholine is so fast is because it only lasts for about 5 to 7 minutes. So its paralysis is also very, 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 very fast. Not instantaneous, but faster than rock. Now, at the high dose intubation, at high dose rock, which is the RSI doses of rock, the speed of onset of paralysis is almost the same as sucks, but it lasts so much longer. So personally, if I had to redose it, I would probably just do half dose, because I know that they're already, by the time I'm redosing somebody, they're already 3 to 5 minutes in. They should be achieving a fairly good degree of paralysis, and I don't need to give them a full dose anymore. Maybe they need just a little bit more. But whenever you give another dose, you also want to remember to give some sedative and not let the sedative not let the paralytic outrun the sedative. Okay, so Good. Okay, so we've done suction, scissors, series. We have confirmed we have a 4-phase square wave on capnography. We're going to confirm placement. Next week, we'll talk about the 7th P, which is the post-intubation management. But for now, and about flying the ventilator for lung protective strategies and all that kind of stuff. But right now, this was meant to be your live demo of an actual RSI sequence going through all the 7 Ps, and pretty much how we'll want to expect you to do it on one of your tests. And don't worry, you will have plenty of opportunity to practice in front of the instructors before you're tested, but this is essentially what we're gonna look at. But do you kind of see now how we have to incorporate all the physiologic information that we had and then put it together and how we apply the 7 Ps? Does that make more sense? Okay, good.
You guys may have intuited this already, but you'll note that like when you become more proficient at this, many of these things will happen simultaneously, right? Like we wouldn't, if we had those vital signs, we wouldn't perform multiple steps and then start BVMing somebody. Obviously, we would see we're hypoxic, we're hypercapping. Let's start BVM, let's doing the pre-ox now while we're doing these other things at the same time.
Right. It's easy to teach it sequentially, but as you said, you're not doing this by yourself. You've got a team. If you see someone who's hypoxic, not protecting their airway, someone's going to get that suction out, someone's going to get the oxygenation out while you're getting your equipment and tools ready and your rescue devices and all that kind of stuff. It's all kind of done simultaneously. However, I guarantee you that before you're actually going to push any meds, you're going through this checklist in your mind. Because again, this is just a cognitive forcing tool, a cognitive forcing strategy to make sure you don't miss anything. So you are going through the 7 Ps whether you realize it or not, and you should do that in real life as you manage the patient. And like you said, by the time you get to pre-medication, hopefully all of the H-bombs you've already been addressing. Yep, check that, check that, check that. I got a line, I'm going to give fluids. I've been giving fluids. And then by the time you are done thinking about pre-medication, the pressure's already 110 because you've had the crystalloid going, you've had oxygenation going, you've got a BVM going. So all of it kind of happens concurrently.
I don't know how Brian likes to do it, but like anytime that I actually do intubate somebody, I will say these things out loud still.
Yep. Me too.
Not only that, but to like keep it straight for myself, but also so that my team understands where we're at in the process and maybe what needs to be done.
And I got to tell you, not only is it good to say it out loud and do it just for yourself, but really to me that's the most valuable thing. Now your whole team knows where you're at thinking wise. Okay, he's at the paralysis with induction phase now pretty much, and so we got to make all these things good and optimal before we push these meds. So everybody on scene knows what he's thinking. Remember we said communicate, communicate, communicate. One of the worst things to happen is that someone's pushing meds and he's not ready, or vice versa. He's ready and blah, 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 and no one's got his meds ready or whatever. So these scenes, when you're actually doing it, can be kind of tense, but this brings order to that chaos, and now you're starting to understand where everyone's head is at, I think. Anything else?
Nope.
Thank you so much.
One of the best people to do this with you every chance is Sean Hagen.
Yeah, very methodical.
Yep.
Goes through the 7 Ps.
Well, yeah, and like, just one other kind of like, if you say everything out loud and somebody's been there with you that also understands what's going on, that's a great way. Like they can help like catch you. Like, oh, hey, you missed something. Like you didn't say this out loud. So, like, did you consider this?
Yep. And many, if not most of our BCs have been through this class, and they can be a second, check for you. When you start talking about the 7 Ps, they know exactly what you're talking about, so they can catch things. Yeah, that's the advantage of them having gone through this as well. So let's say that we have a patient. Let's use the same patient since we know what's going on. In spite of fluids, in spite of O2, supplemental O2, and optimizing O2 oxygen flow, they're in the pre-medication phase, their H-bombs, one of the H-bombs is just not getting any better. Or there's something that's just not optimal, and you decide, man, the worst thing I can do right now is do an RSI on this patient. Then what is your other option? DSI. You can do a delayed sequence induction where you're trying to buy even more time to help prepare this patient as optimally as you can to secure an airway. So you still have your 7 Ps, so to speak, but in this case, you're giving a little bit of medication first. Remember, we said that in RSI and DSI, the first two kind of trade places. The sedative goes first, and then oxygenation, because what you're doing is you're trying to optimize the patient's status before, buying time to resuscitate them and pre-oxygenate. And again, it does not assume that you have to use a paralytic. You might not. You might not. But those 3 classes of patients that this might be helpful: refractory hypoxemia. So no matter what you do, you just cannot get above that 92, 93% mark. Severely hypotensive, very shocky, severe acidosis. Okay. Remember, we kind of talked about the aspirin overdose and DK air, right? One of the worst things you can do is get them intubated and then leave them on standard vent settings without considering why they're so tachypnic in the first place, that why their minute volume is so high in the first place, and all these things. One of the worst things you can do. What can you do to maybe buy a little time for these 3 types? Well, you're still going to want to prepare. You're still going to try to get backup airways, do your racer, and look for things that you can possibly head off at the pass, so to speak, as far as problems you can reverse. And then you can give your induction agent with no paralytic, so a little bit of sedation if necessary. In this particular case, where the patient is already pretty obtunded with no gag reflex, you may or may not have to give a sedative to buy some time. However, in this particular case, if they were persistently hypotensive, the ketamine actually might help. You know, ketamine is not a pressor, but one of the side effects is it raises blood pressure. And so I love it if you have to give to somebody who needs a little bit of sedation, but they're pressure soft. This is a great drug to consider. You still want to do as much positioning and pre-oxygenation as possible. Assuming you do hit a time point where you can get them intubated, you want to be ready for that moment because you don't know how long that window will be open. You're still going to ponder before you give any medications. In this case, we gave fluids. You can give a crystalloid, LR or NS, a bolus. We used to give lidocaine, like pre-medicated lidocaine, supposedly to blunt the sympathetic response, but parasympathetic rather, but that's really fallen out of favor. Giving people pain control is always good. If they happen to be a little bradycardic, maybe optimizing their heart rate a little bit with a little bit of atropine is okay. We talked about that defasciculating dose, which is what fraction of rocuronium? Is it an 1/8? Is it a 1/4? A 1/10? A tiny dose, a 1/10 of a dose of rock maybe to give a defasciculating dose. Again, you may or may not give phase 5, which is a paralytic. Just because you started down the DSI path doesn't mean you can't. If you decide that things are now optimal and that, hey, everything has improved a great deal and maybe we can give the paralytic and do it, then great. Otherwise, you can forego it. But then, if you are able to get enough of a visualization and there's no significant trismus and you can place without the paralytic, then you can. Start with suctioning. Remember, we always said introduce the Ducanto before your endotracheal tube. Decontaminate your airway. Optimize that as much as you can. Progressive intubation. If you would do me a favor, because I didn't catch this before we printed, go ahead and draw a line through that third line that says place the Miller and withdraw looking for cords. Remember, we don't want to do that. We want to do progressive laryngoscopy all the time, progressive laryngoscopy. And then, in a difficult airway, your bougie is always a great tool to use, just like you saw in the video. And then phase 7, post-intubation management, we'll do that in great detail next week. But you're reassessing your vitals, you're making sure you don't give any rescue vasopressors. You're going to set your Hamilton T1 to be lung protective strategies. All that stuff will go into great detail next week.
Is there a preferred inopressor that you would give for post-intubation management?
Yeah, you know, a lot of times if we think that really they just need a little bit of a squeeze, their heart rate's fine, blood pressure's off because you think the tank just got too big for whatever reason. Like let's say you choose etomidate or propofol as your induction agent, then what would you think would be the best agent to use if all you need is to make the tank a little smaller? Not a bad choice, but can you think of an agent that purely works at the alpha-1 receptor and makes the tank smaller without affecting anything else? Phenylephrine, you know, that would be a great choice. So really it's about, the answer to your question, like what is the underlying problem? Like, do I need a little bit of just chronotropic support or inotropic support, a little bit of both, versus just making the tank smaller? If you need a little bit of both, then epi, great. You know, we're using push dose epinephrine more and more. Gives you a little bit, it works on both the alpha and the beta receptors. So one of the biggest challenges as a critical care paramedic is not necessarily having a strict algorithm to follow like most paramedics are used to, you know, if this, then that. But remember that now you're gonna think, if this, then I have options A, B, C, and D. Well then, what is my patient's actual underlying problem? And by that, you'll know whether option A, B, C, or D is better. So one of the most difficult things for you to do as a critical care paramedic is transition over to that. Instead of if this, then that option, if this, then those options, and really thinking through the whys and picking from that point on. Does that make sense? Right. Need 5 or? Yeah, take 5. All right, hang in there. We're in the final stretch. We are now in the last section of this marathon day. We've gone through physiology of breathing, all the hardware tools, airway management principles. We've gone through the 7 Ps, the process of direct and indirect laryngoscopy and intubation. Now we're going to talk about a little about the pharmacology of intubation. So we've talked about these meds. But something else you're going to have to know as a critical care paramedic is how do these meds work? Like what receptors do they bind? Why would we choose one over the other? What are the doses and contraindications, indications, all that kind of stuff. So that's what we're diving into next. We are going to focus on the induction agents and sedatives, and then we're going to investigate the paralytics themselves, okay? Let's jump into induction to agents and sedatives. There are 3 classes that we will be focusing on, 3 of the most common classes that you will use in your practice of medicine. The first class is the GABA receptor agonist. The second class is the NMDA receptor agonist. And finally, the alpha-2 adrenergic receptor agonist. I find it is easier to kind of break it up in those classes and talk about them that way. Instead of talking about 5 different induction agents, we just talk about 3 classes and the ones that belong to each class. That's how I think. So let's look at the GABA receptor. Oh, and then the neuromuscular blockers are going to be succinylcholine, and then ROC, VEC, and cisatracurium, Nimbex. Why do you think that Sux is the one that has a little lightning bolt up next to it?
That's the question.
Because it's depolarizing.
Because it's the only depolarizing paralytic. The rest are non-depolarizing. So yes, it is a test question.
Our answers were better.
Yep. And then it is the fastest because it's depolarizing. But the primary reason is because it is the only depolarizing drug. So whenever you're studying pharmacology and you hear something like, it's the only whatever, that's a test question, okay? So let's go with first our induction agents and sedatives, the GABA receptor agonists, of which there are 3. Etomidate, propofol, and midazolam. You cannot just say just benzodiazepines in general, but midazolam being one of the most common induction agents that we use for airway, right? So let's look at first, what is a GABA receptor? GABA, this is a little bit confusing because GABA is both a neurotransmitter, but GABA is also the name of the receptor. So that can be confusing to people. So GABA is the neurotransmitter itself. GABA is also the name of the receptor to which GABA binds to. GABA binds to GABA. Okay, so just know that that is why some people can be confused. The GABA A receptor is mostly in the brain and central nervous system. So there is a GABA B, there is a GABA C, I think there's a GABA D delta as well. But my point is this, that because we're talking about airway management, we're talking about sedatives in the brain, we're going to be talking about GABA A receptors. Okay, so GABA A receptors. The GABA, the neurotransmitter, is the body's primary inhibitory neurotransmitter, which means it calms the nerve impulses in the brain. This is why it's a sedative, not a stimulant. Okay? So what does agonist mean? What does antagonist mean?
Agonist means to produce a response, and antagonist would be for blocking.
To blocking, right. So you can think of it a number of ways. Agonist is to promote the action of the subject, antagonize to block or inhibit the action of a subject. In this case, it's the subject is a receptor. So an agonist will enhance that receptor's action, an antagonist will block it. So the mu receptor is what painkillers, opioids bind to, right? So fentanyl is a mu receptor agonist. Narcan is the antagonist. See, it blocks it. See? Okay, good. So GABA is the primary inhibitory neurotransmitter for the GABA receptor. GABA stands for gamma aminobutyric acid. Okay, but GABA is way easier to say, so we just say GABA. Okay. Now, when we talk about protein ion channels and electrolyte charges, GABA is one of these channels where ions will influx or efflux, meaning move in or move out, through these protein channels, right? Makes sense so far? What are these ions? These ions can be chloride ions, sodium, calcium, potassium. In this case, GABA, any of these protein ion channels and electrolyte charges can move about, influx or efflux, as a result of changes in the cell membrane potential, which results in the cell responding with either activation, or you can think of it as stimulation, or inhibition, in other words, or if it's antagonized, right? Now we're throwing around all these terms like potential, and I have found that a lot of medics don't understand even what is a potential. When I say a potential, specifically when we talk about nerve impulses and sedatives in the brain, like these induction agents, we have to know what an action potential is. So first of all, what is the action potential? Well, no problem, we're gonna make it easy. First of all, let's start with the fundamentals. There's no life at all without a cell, including nerve cells, right? And there's no cell without a cell membrane. This is the functional, basic structural functional unit of life. The cell membrane is made up of a phospholipid bilayer. Phospholipid, exactly the sound, a phosphorus end and a lipid end. The phospholipid bilayer, the hydrophilic head means water loving. Hydrophobic tails are water hating, right? Phobia, phobic, so hating, not liking. So the cell membrane is consisting of this phospholipid bilayer without which a cell cannot exist, including neurons, nerve cells. So when you look at a typical phospholipid bilayer membrane, all kinds of things are embedded in that cell. That's how cells work, right? Without receptors on it and channels on it, how are cells supposed to interact with the body? It has to interact with the body, okay? So buried in the cell membrane are all these things like protein channels, signal proteins, glycoproteins, all these different things that help a cell function. The second thing we need to define is what a potential is. When I say potential, I mean the electrical difference between the outside and the inside of a cell. If I were to make this super, super tiny voltmeter and stick it into the membrane like this, the recording microelectrode would tell you that the cytosol, which is the inside of a cell, is more negative than the extracellular fluid or the outside of a cell. You follow so far? What is that difference? Well, looking on the voltmeter, it's about 70 millivolts, meaning that there's about a negative 70 millivolt difference between the inside and outside of the cell. Typically at rest, this is the resting potential. When nothing is happening in the cell, it's just floating around doing nothing. it's at about minus 70 millivolts, okay, typically. Think of a potential like money. Remember I said that cells have to interact with the body, and it does that by exchanging currency, money. And a potential is a form of currency for all cells, and it drives things like energy production, signaling between cells, and the transport of stuff, sugar inside of a cell, for example, through sugar transport channels for energy. If you don't have it, you die, right? So this is an example, however, of a graded potential. A graded potential means a ligand or a signal of some kind can be released by one cell. It binds to the receptor of a target cell. It creates a response in that target cell, whatever you want it to do. If that cell doesn't have that little blue receptor, you can have all kinds of ligands surrounding this cell and nothing will happen. There has to be a receptor. You follow so far? So this cell, it doesn't care how many yellow circles are floating around, but this one does because it's got a blue receptor to take that yellow circle. Okay, a ligand and a receptor. A graded potential means it responds to various grades. In other words, if there's only a few of those yellow circles or substances, whatever the signal is, then you get a little bit of response. But if you've got a ton of those, you get a ton of a response. So it's graded, okay? Action potentials, however, are different. It's an all or none phenomenon. Either it signals or it doesn't signal. And the easiest way that I could explain this is using a trombone for graded potentials and a pistol for action potentials. If you compare the two, with a graded potential, the amplitude varies with the stimulus. Like I said, if you've got a little bit of a signal, you get a little bit of response. Big signal, big response. So like a trombone, the notes get lower the more you put the slide out. It gets higher the more you pull the slide in. It all depends. It's graded. Unlike piano keys, which has specific notes on a key, you can't play keys in between, notes in between. A trombone, any trombone players in here? You can, there's no keys on a trombone, right? There's an infinite number of notes you can play depending on how far you slide in and out. However, a pistol, once a threshold is reached, it gives you a response. The same response every time. That's an action potential, okay? There's no in between. The gun didn't kind of fire. Either it did or it didn't, right? If you pull the trigger harder, the bullet doesn't go faster. It will go fast. It'll go the same speed whether you pull it slowly or pull it fast, okay? Unlike a trombone where it's graded. In trombone, there's no threshold. It's just however much stimulus there is. But in an action potential, there has to be a threshold. You can pull that trigger back 4 pounds on a 5-pound trigger, but unless you hit that 5th pound, it won't fire, right? So it has to reach a threshold and then click. Once that hammer falls, it'll fire. That's a threshold for an action potential, okay? In a graded potential, there's no refractory period. It'll keep firing as long as there's ligands, as long as there's yellow circles. Whereas in an action potential, there is a refractory period of some kind. All these different things are just to say that graded potential and action potentials are two different things. I just wanted you to know that there is a difference. For purposes of our discussion, we're talking about pharmacology, and we're talking about nerve cells, and we're talking about induction agents like etomidate and propofol dampening a cell's signaling to calm the brain, for example. We're going to be talking about action potentials mostly, okay? So action potentials are caused by depolarization. They can travel long distances, and GABA type A, as I said, GABA A's are mostly in the central nervous system. Now, potentials can change in a number of ways. It can either be resting, like we said, and what is the typical resting potential electrical-wise? Minus 70 millivolts, about. Depolarization of that potential means you're slowly squeezing that trigger, right, getting closer to the threshold. If it's a 5-pound trigger, you're at 4.5, you're still not there. But once you hit that 5th pound, boom, it triggers an action potential. But then there is a repolarization of that potential back to resting, which means no matter how many times you give a stimulus, it won't fire because there's a refractory period, right? It's kind of like the pistol as well. You can keep pulling the trigger back, but unless the slide ejects around, feeds enough from the magazine, puts it in chamber, the slide goes forward, it's not able to fire again, no matter how hard you pull the trigger, right? Same with action potentials. There is a refractory period that it has to reset itself. Okay? But relax, we're going to break this down step by step, because we said that the cytoplasm, which is the inside or the outside of the cell? Inside, the cytoplasm is net negatively charged, about -70 at resting. Outside is net positively charged, and this resting potential is maintained typically by the sodium-potassium pump. I'm not talking about the action potential, I'm talking about the resting potential right now. And this is an active transport mechanism. You exchange 3 sodiums, get ejected from the inside of the cell outside the cell, and then when that sodium-potassium pump is phosphorylated by energy, ATP, it ejects those 3 positives, but it brings 2 potassiums in. So are we net positive or negative on the inside? 3 for 2. You're getting rid of 3, but only bringing 2 positives in. So eventually you're going to be net negative. You're losing positives every more than negatives, right? So that's how the inside maintains its negative charge, through the sodium-potassium pump. Lets 3 go, brings 2 back in. Now, at rest, this is how it maintains that negative charge. Active transport, sodium-potassium pump. These are closed voltage-gated sodium channels, and the closed voltage-gated potassium channels, the only thing that's functioning is that sodium-potassium pump to maintain the negative potential, right? Now, when depolarization happens, suddenly the inside of the cell is becoming more positive. Well, how does that happen? Well, by the time that negative goes from -70 to about a -55, that is the typical threshold by which an action potential is triggered. So the question becomes, well, what makes it more positive? Well, a sodium channel opens. Now you've got more sodium, which are positives, come in, and now the inside, here's that probe there, right? That little red needle is your invisible probe that's measuring the difference. Now instead of -70, it becomes -65, -60, -55, and once it hits -55, that triggers an action potential. That gun fires, that nerve fires, okay? So here's that threshold. You get some kind of stimulus which opens the sodium channels. It hits -55, and boom, there goes your nerve signal down the neuron, okay? If this is a nerve cell, okay? Because it becomes more positive. Well, the opposite of depolarization would be hyperpolarization. What if we moved this red line from -70 down to -90? Will you need more stimulus? Will it take more energy, more to move that up to your -55 threshold? Sure, because if you go from -70 to -100, you're going to need a lot more trigger pull to hit the threshold, right? And in other words, it makes it harder to activate a signal if you hyperpolarize a cell, and that's exactly what these GABA A receptor agonists do. How is that? Because when you make a nerve cell hyperpolarized or more negative inside, you essentially put it to sleep. And that's what these sedatives do. The GABA receptor agonists put the nerve cells to sleep. Your brain is inhibited, calmer, you get the sedative effect, because now 70 goes down here, you're more negative, and more trigger pull is needed to hit threshold, okay? The GABA receptor, if a benzodiazepine, for example, which is a positive modulator, binds to the GABA A receptor like that, there's the benzo, it's gonna hit, that makes the GABA receptor even more active, and more chloride ions goes inside the cell. Well, chloride is negative, right? So now what's happening to the charge inside the cell? More negative, it's hyperpolarized. So now you're depressing that baseline in negativity. It takes a lot more energy to hit threshold. Now that nerve cell is being sedated, okay? So this is why benzodiazepines, barbiturates, propofol, alcohol, these are all positive modulators of GABA A. It hyperpolarizes the cell. So it reduces excitability in the brain. You've got more chloride ions pouring to the inside of the cell. It makes it more negative. It can't fire anymore. You get a sedation and a sleep-like state in which the patient is sedated. because you raise the activation threshold of the brain cells. This also makes it an anti-seizure, gives it anti-epileptic properties as well. Okay? Now remember, this is not an analgesic. There's no pain control here. It just puts them out, it puts them to sleep, which is why after intubation, for example, or giving sedation for a reduction of a femur fracture or a hip dislocation, we always want to give a little bit of fentanyl with it because there's your pain management. Okay? The brain neuron, the resting potential is negative, as we said. Sodium equals activation because it's positive. When the sodium channel's open, you depolarize it. This excites the brain. But chloride inactivates it because it hyperpolarizes the cell, and now it inhibits the brain and kind of puts it to sleep. Okay, so that's one way of thinking about it. Okay. Potassium leaving the cell also inhibits the brain because potassium is positive and it can make it more negative inside the cell. So let's be clear, when the patient receives etomidate, propofol, Versed, these are all positive modulators of GABA. Another way to call it is a GABA receptor agonist or antagonist? Agonist, because it revs up the GABA receptor and more chloride ions come in, okay? And that's what hyperpolarizes the cell, right? Chloride binds as a positive modulator. It enhances GABA, makes this inside more negative, increases the threshold, makes it harder for an action potential to fire off, causes central nervous system sedation. So etomidate causes a global depression of the central nervous system. It is considered a stable medication with little impact on hemodynamics, not necessarily increasing BP or heart rate. Supposed to not decrease it either, although I've seen it sometimes decrease it. Very short half-life, 10 minutes at the most, maybe even shorter than that. It's considered neuroprotective, slows the brain's metabolic rate, maybe helps decrease ICP. If you give it with another GABA-A agonist like Versed, you're going to increase the inhibitory effect and sedation. Right? So combining GABA-A receptors together can significantly cause a lot of sedation. And then may in fact also start having hemodynamic effects on top of that. It is known to inhibit cortisol production, so people with known adrenal insufficiency, you want to be careful about that. Theoretically, you can just throw them into Addisonian crisis. I've not seen that, but regardless, if I know someone has a history of Addison's disease or adrenal insufficiency, I'll try not to, I'll use another sedative. Okay. What you could do is give some steroid to restore cortisol levels affected by etomidate if that's what you think is happening. An interesting side effect of etomidate is sometimes it can cause trismus. So if we're doing delayed sequence induction with no paralytic and we choose etomidate for whatever reason, and they clench, not good, right? That's why it's not a great single agent for intubation. It can also cause some myoclonus, some skeletal muscle twitching. It can be confused for a seizure, but it's not a seizure. So just remember that. Sometimes if you see that, it may just be some myoclonus. We're going to have lots of slides like this where we have indications, contraindications, onset of action mechanism, and effects, side effects. These are all incredibly high yield, easy fodder for quiz questions and test questions. So spend some time with each of these. I don't intend to read every slide word for word because you're all adults, you can read it, okay? If you're not spending probably 2 to 4 hours a day outside of class, you should rethink. You need to be spending at least that much every day. Okay? So go over these things, start memorizing. This is the thing about pharmacology. Like everything in medical school, like especially cardiology, I loved cardiology. You know why? Because it's practical. Like if you understand how valves work, then you don't need to memorize valve disease. You just have to know that regurgitation and stenosis, if you know how a valve works, you know what the problems are, right? It makes sense. Pharmacology, there's no other way than rote memorization. You just have to sit down with flashcards. Most students make flashcards with this information on it, or they'll copy the notes, cut them out into little flashcards, and just while they're sitting on the pot, in the grocery store line, you're just going through these. There's no easy way, but just rote memorization. So spend time with it. Indications, contraindications, onset, mechanism, and effects, okay? Side effects, your doses, all of this is really easy fodder. So etomidate, 0.3 mg per kg to a max of 40 milligrams, usually 30 to 40, okay? Propofol, milk of amnesia, because it looks like milk, okay? This is a very commonly used sedative in emergency medicine and critical care. Why? Because it is so effective. It's very quick on, very quick off. Because it's very quick on, it's great for just very short but painful procedures like a hip reduction or something like that. Because it's in a lipid emulsion, it has this milky appearance. And it does have amnestic effects. So milk of amnesia is a common slang term for propofol. Now remember, because this is a sedative hypnotic at the GABA-A receptor agonist, it doesn't provide analgesia either. So no pain control. This is just an amnestic sedative, okay? It's a great medication for neuro checks because if you need to do a neurologic check, you just turn the thing off and it's gone. And you can get your neurologic exam and make sure that they're not too sedated. Especially when you use this as a bolus, it can really cause a profound drop in blood pressure. So propofol is definitely not the best thing to give for people whose blood pressures are a little bit soft. Great for people that you want to give some sedative to that's hypertensive to begin with. Rarely it can cause dystonia, manifests as abnormal like posturing, dystonic reactions in patients. It can also cause propofol-related infusion syndrome or PRIS. This is usually going to be in the ICU, not in the back of your ambulance. So if you're going to give propofol infusions while you're transporting, that's fine. Now it is one thing that if they've been on propofol for 2 days and now you're transferred into Big Barns or Mercy downtown or whatever, well, just know that they've been on it long enough that they may have PRIS, which is dysrhythmias, metabolic acidosis, sometimes hyper-K, rhabdo, renal failure, at the extreme, cardiac arrest. But just know that that is not something that's going to happen if you happen to start it yourself during an inter-facility transfer. It's usually after a couple days in the ICU. Know these things, as we said. One of the pearls to know is that it can promote bacterial growth. Yes?
Can you guys add a new thing to this? Bolus dose. Write down bolus dose next to first dose. And
Oh, yeah.
Bolus dose is 0.1 to 0.2 milligrams per kilogram. 0.1 to 0.2 milligrams per kilogram IV push. That's when you give a bolus with an infusion. And we'll talk more about that when we get to respiratory, things like that.
0.2?
Yeah, milligrams per kilogram.
Milligrams or micrograms?
Milligrams per kilogram. Yeah.
That's different than the 1 to 3.
That's different from the 1 to 3. That's for induction.
Okay.
The 1 to 3 is for induction. If you're going to use it for induction, which we don't do that here, but you still need to know that dose. A bolus dose is just giving a bolus to help with sedation. Like I said, we'll talk more about that later. That's a much smaller dose, 0.1, 0.2 milligrams per kilogram.
Yep. Interestingly enough, if you do rotations with anesthesia, they'll have their case log in front of them on their cart. They'll say, okay, I'm doing 6 cases today or whatever. They'll know what all the patients are. They usually have met them the night before, done all the pre-op work. They will typically pre-draw and label all their syringes for each patient so that they don't have to do it throughout the day. This is for patient A, B, C, D. The one thing that they will not pre-draw is propofol, because even the 45 minutes to an hour that it's sitting on their cart unrefrigerated is enough that it can start growing bacteria if there's the slightest hint of contamination. That lipid emulsion is just like nutrient rich, right? And so they will not pre-draw up their propofol like every other medicine that they have. They'll draw it right before they're ready to use it.
So
And
propofol is refrigerated?
yeah, it needs to be. Yeah, yeah. Versed is the third and final GABA-A agonist that we're going to talk about. Versed being the prototypical benzodiazepine, very short acting. It speeds up the influx of chloride ions, rather like all the other GABA-A agonists do, which hyperpolarizes the nerve cell, puts it to sleep, causes sedation. Like all the other GABA-As, no analgesics. If it is used for induction, it's often mixed with an opiate like fentanyl to give that analgesic effect. It is a little slightly longer in onset and action when compared to propofol and etomidate, which are very, very fast. Normally, there is a slight blood pressure effect, significantly, particularly hypotension, definitely respiratory depression, decreased cardiac output like all your benzos can do. When given over 48 hours, in other words, repeatedly, you can increase the risk of ICU delirium. So other medicines like Precedex, which we'll talk about last, may be better for things like that. They could do Precedex drips, for example. The reason why Versed by itself is not often used as an induction agent is because, do you know that according to the package insert, what an induction dose for intubation could be of Versed? Up to 40 milligrams, like at a time. It's ridiculous. And so, yeah, it's not often used as the sole induction agent. I love Versed for post-intubation management. I'll induce with etomidate or ketamine, but then do the post-intubation sedation with Versed rather than give a 40 milligram bolus of Versed. Know your usual stuff here. Your infusion doses can be as high as 90 milligrams an hour, depending on what's going on with the patient. It's a great sedative to use in patients with alcohol withdrawal as well, because what does that do to the seizure threshold? It increases it greatly, right? So it reduces the chances of alcoholic withdrawal seizures, and it kind of calms the delirium tremens, the DTs. So it's also good, okay? Versed infusions can be given through your pump, can be given through infusion pump as is shown there. Versed infusions on a PC, did that mean to see PCA, Chief? Okay. I've seen fentanyl on a PCA. I don't think I've ever seen Versed on a PCA.
And that, I showed that picture, it's weighing at 90, and that was a real patient.
Oh, that is the
Yeah, I've seen the dose, it's weighing at 90.
Oh my goodness. That's a lot. That is crazy. 90 milligrams an hour. That's a lot.
Was that your pump?
Yeah, that's
What was
probably,
their deal?
I don't remember, it was way back.
But he said,
Feeling
They were
amazing.
ventilated, I can't remember
Yeah.
what it was. So.
Man, that's crazy.
that's a lot. I don't think I've ever seen 90 milligrams an hour.
What's the toxic dose?
Good question.
So remember, unlike barbiturates, where the curve is almost straight, with benzos it kind of curves. That's why benzos are preferred over barbiturates. There really is no toxic dose per se. It's dependent on the patient. Like, are they GABA naive or GABA tolerant? Like, have they been on GABA receptors for a long time and therefore their tolerance is much higher? They need higher doses to get the same effect. Versus someone who's never had a GABA agonist before, they only need 10 milligrams and they're out. So it really is very patient dependent, but benzos are as safe as the patient will tolerate it, mostly. So. The next class is the NMDA receptor agonist, and there's one that we're going to talk about, that's ketamine. What is N-methyl D-aspartate? NMDA, the NMDA receptor primarily binds glutamate and glycine. Glutamate is the brain's primary excitatory neurotransmitter, whereas glycine is primarily an inhibitory, although it can act as a co-agonist with glutamate on NMDA specifically, which is why both of them are shown. It is primarily a sodium and calcium channel, kind of like what GABA is for chloride, NMDA is for sodium and calcium. So what does it actually do? It controls a lot of neuroplasticity, meaning communication, memory formation, overall brain health. It's very susceptible to outside influences and medications. It does have what's called an allosteric binding site, allosteric meaning malleable. Various things may or may not bind to a high or low degree depending on its molecular shape, which can also affect the shape of that channel. But it works through a different mechanism. So whereas, remember we said that GABA A agonists make the chloride ions flow faster through the channel. When glutamate binds to NMDA receptor, it causes activation and stimulation where magnesium dislodges because sodium and calcium are fluxing into the cell. And now that that cell is open, ketamine actually runs in and blocks it. It runs right down the central channel and kind of acts like an obstruction through the channel. And it inhibits any further movement of sodium and calcium, which basically blocks its effect. Because ketamine blocks that receptor, there's no glutamate or stimulation of the cell can now occur, which makes ketamine an NMDA antagonist, and that will result in your sedation and amnesia and anesthesia. So that's the mechanism through which it works.
We have it as an agonist on the introduction side.
Oh yeah,
Change that?
that should be an NMDA receptor antagonist. Yeah, please correct that, thank you. It actually lodges through that central canal and blocks sodium and calcium channels, yes. Thanks for catching that. So it is very short acting. At low doses, it can be a primary analgesic. Mid-range, like what's called sub-dissociative. It can also be in kind of in between there. The patient knows that you're messing with their dislocated ankle, but they don't care. They can sometimes even watch it, and they don't care. They dissociate. At higher doses, they can completely dissociate. And at really high doses, you can induce people for intubation with it. It's a potent sedative. So really is dose dependent. Now, high doses of ketamine might induce hypersalivation. In that case, you can give a little bit of atropine. Those mid-range doses are associated with emergence phenomenon. Have you ever heard of that before? Emergence phenomenon. It used to be much more evident in children, where as the ketamine is wearing off, they get really delirious and they see things, they get really afraid. So in kids, if they get ketamine for anything, sometimes they'll get a little bit of a benzo with it to reduce the incidence of emergence phenomenon, where they hallucinate and see things. Okay? Like 2.5 to 5 milligrams you can give for emergence phenomenon. It is proadrenergic, meaning it increases blood pressure and heart rate, increases your MAP and cardiac output. Nystagmus may be present as well as hyperemesis. The cool thing about ketamine, because it raises blood pressure often and causes tachycardia, is if you mix it with propofol, it kind of is the yin to its yang and kind of balances it out a little bit. So you don't get the hypotension associated with propofol, you don't get the hypertension associated with ketamine, and together it works as a great analgesic sedative. So the colloquial slang term for mixing it is ketofol. Ketamine plus propofol is ketofol. So
on transfers, guys, if you get a patient on propofol, it's totally okay to provide more sedation with ketamine. Okay? Just don't give it at the induction dose, but we do it on transfers all the time.
yep, and if you put it in the same syringe, which they are compatible, you can do that. It's ketofol. So we'll do like 40 milligrams of ketamine, 40 milligrams of propofol in a single syringe, and just slowly push that in until they're nice and kind of dissociated and they're sedated at the same time. They have a little bit of analgesia at that dose with the ketamine as well. And man, you can yank on their ankle or their dislocated knee and they're like, it's great. And it's relatively short, so by the time you're done with your procedure, hopefully they're waking up. So it's really good. At high enough doses, again, like I said, you can induce someone for intubation with that. It's great for procedural sedation. It's contraindicated in anything where hypertension would be bad by itself. So blocks the glutamate from attaching, closes the receptor, and blocks its effect, making sedation and amnesia. Here are these doses.
You do need to memorize those doses.
Yep. Again, there's no easy way. You just have to memorize these over and over repetition. No mnemonic, no helpful thing. Just memorize it. Finally, the alpha-2 adrenergic agonist Precedex. Alpha-2 adrenergic receptors. Remember, adrenergic relates to adrenaline. So if you hear this is an adrenergic receptor, it means it responds to adrenaline or noradrenaline. By the same token, a cholinergic receptor responds to what? Acetylcholine. Good. So alpha-2 adrenergic receptors are G protein coupled receptors that that respond to dexmedetomidine, better known as Precedex. Now, Precedex activates these receptors, so these are agonists, causing an effect similar to the GABA A agonist, resulting in CNS depression, sedation, analgesia. Okay. But it reduces neuronal damage by inhibiting neurotransmitter release and inhibiting the activity of the sympathetic nervous system. So what's nice about it is that it's very short on, like onset within a minute or two at the most. You can turn it off pretty quickly. It inhibits neuronal messaging, produces sedation, and a little bit of pain control. It can cause bradycardia and hypotension. When compared to other sedatives, it's not as powerful, but its advantages of being super fast on and super fast off are really helpful. All right, so those are induction agents and sedatives. Next section is our neuromuscular blockade agents, or NMBAs, better known as paralytics. Unlike a lot of our sedatives, which are better known by their trade names, these are better known by their generic names. So no one calls it anectine, they call it Sux. And no one calls it Zemuron, it's just rock or rocuronium. Okay, so vecuronium, cisatracurium, these are all these other NMBAs. So how do NMBAs work? We're the neuromuscular blocking agents. So we should spend some time talking about the neuromuscular junction. A neuromuscular blockade agent paralyzes the muscle, right? And in the case of RSI, the muscle that we care about the most is the diaphragm. And then the second muscle we care about is the masseter. For trismus, it relaxes the jaw, makes it easier to get that 3-3-2 going, okay? Now, of course, it will also relax all the other skeletal muscles in your body, but the ones we care about the most, diaphragm, masseter muscles, jaw muscles. So here you have an example of a neuromuscular junction. Here's the axon terminating at the neuromuscular junction where there are receptors at the end plate of this muscle. So what do these little vesicles represent? Vesicles containing your neurotransmitter, like acetylcholine, for example. And if it releases this at this, what do you call this gap between the axon and the muscle end plate itself? There's a scientific name for that gap. It starts with an S. Synapse. Very good. The synapse. So when that vesicle releases the neurotransmitter into the synapse, those blue dots represents your neurotransmitter. It'll bind these receptors and initiate a response. Well, this is where neuromuscular blockade agents work, at the junction, at the synapse between the neuron and the muscle itself. So normally acetylcholine leaves the vesicles, travels through this junction and lands on the muscle receptors on the cell wall, making it contract. Here is an example where acetylcholine is released from the neuron, triggered by that influx of calcium into the end of the neuron, allowing acetylcholine to move from that neuron through this neuromuscular junction to the motor end plate, binding to these receptors and causing a contraction. Now, once that neuromuscular junction, once across it, acetylcholine binds to these nicotinic acetylcholine receptors, which are the sodium-gated channels. Remember we talked about the sodium-gated channels causing an action potential? Once those sodium-gated channels open, all that positive sodium enters into the cell, and what does that do to the inside? It becomes more negative or more positive? Yeah, because sodium is positive, it becomes more positive. You hit your threshold, you get that action potential, that nerve fires off, and now the muscle can contract. So enter your NMBA. These work to bind the receptors on those muscles. And what happens if those receptors are now bound by something else? The muscles can't contract, right? You paralyze those muscles. That's how these NMBAs work. Now, there's two different ways they work. They either depolarize that motor end plate, or they just competitively bind it fairly weakly, okay? Nonetheless, it blocks the neurotransmitter from sitting on that receptor and activating a nerve impulse. That's why they paralyze the muscle. Make sense? So depolarizing neuromuscular blockades, of which there's one, which is depolarizing, the only one, succinylcholine, very good, are non-competitive. They simply basically fire off the pistol without allowing it to recock, right? It pulls the trigger and then it never lets the trigger go forward to reset itself. It just fires off and then That's it. That's why you see these little muscle defasciculations, because it's firing these motor end plates, and you can see it wiggling underneath the skin, okay? Whereas the non-depolarizing are merely competitive. They bind the receptor, but it doesn't cause it to depolarize necessarily. It's non-depolarizing. It just sits there and blocks it, just like, you're not going to bind here, but it doesn't cause an effect downstream. So that's why they're categorized as depolarizing and non-depolarizing based on how they interact with that acetylcholine receptor. Yeah.
Yeah, and the non-competitive means that acetylcholine can't fight with it. Succinylcholine is going to win every time.
Mm-hmm.
So there's no competition there. That's what it means by non-competitive. So succinylcholine cannot be kicked out by acetylcholine or anything else. It's just going to have to wear its time. Non-depolarizing are competitive, they're weaker. They bind weakly, so they can be overthrown by high doses of acetylcholine or other reversal agents. So rod can be reversed and sucks can't, and that's why.
Is that why we carry rock instead of the other?
One of the reasons why. I mean, there's primary more reasons.
Right.
But riboflavin can be reversed. Succinylcholine is going to stick
Right.
with Gorilla glue.
Yep. And to Chief's point, this is why there is no antidote to succinylcholine. You just have to let it run its course and eventually become metabolized and move off of the receptor. But only time will let that happen. Now, the good thing about Sux is that because it is so short-acting, you don't have to wait very long. In fact, at a lot of places, there are, so this is actually a good place to introduce this controversy. There is one camp that says for emergency airways, where you don't know the patient at all, they're not NPO, you're not sure if you can get this tube or not, you've done no pre-op prep, you don't know anything about this patient, a fast-acting, depolarizing paralytic like succinylcholine is better. The rationale being this, that, well, if we paralyze them, but we can't get this tube for whatever reason, we had no way of knowing that there was going to be a difficult airway or a failed airway, whatever, we can usually just bag them until they wake up, until they breathe on their own, and we can do something else, right? Because the fear is if you paralyze somebody and they can't breathe, remember, you either get a tube or they die, right? Unless you can breathe for them through that paralysis. Well, a few years ago, there was another camp that says, well, wait a minute here. If you can't get the airway, it's not like they don't need it anymore. You still need an airway, and when do you start moving towards your emergency backup plans? Is it 30 seconds after you start or like 3 to 5 minutes after you start? By the time you get to your emergency backup plan, about how long has passed? Probably 3 to 5 minutes. So the time that you're going to use your iGel, or the time that you're going to use your other adjuncts and try plan B or whatever for this emergency airway is about the time that the Sux is wearing off, right? So now the diaphragm starts to come back, they could puke. The skeletal muscles are coming back, they could clench. So they say, really, what you need to do is give rock that lasts 30 to 45 minutes. So that really is get an airway, oxygenate them, or they die. But then you also have an unencumbered pathway through your emergency backup plan because they're still paralyzed. So you're not fighting them, in other words, or redosing them with Sux again, which is not a great thing to do. Okay? So one camp says, short-acting, quick depolarizing drug, better in emergencies. Another camp says, for the very reason that it's an emergency, you should use a longer-acting, non-depolarizing paralytic so that you can have unencumbered access to your rescue algorithm pathway. You see the two warring sides? So some hospitals still use etomidate and Sux as their primary. Others use etomidate or ketamine and rock as their primary RSI. For the longest time, I was very much of the short-acting depolarizing camp. But the more experience I've gained and the more difficult airways I've had to manage, the more wisdom I see in the R. Adams Cowley shock trauma protocol, which for way before their time, they were using the non-depolarizing long-acting rocuronium for their RSI. Anyone ever heard of Cowley shock trauma in Maryland? One of the first in the country to actually have a separate trauma section in the emergency department with much better mortality rates because that's all they do. And one of the things they've done way before anyone else adopted it was this concept of a longer acting, like non-depolarizing paralytic, so that they can just move through their algorithm without fighting the patient. Because they say, look, it is rare that you can't oxygenate, can't intubate, can't ventilate. You can do something, even if it's a difficult airway. But they said, heck, if we can't, guess what we're going to do? We're going to crank them anyway. So they've been doing this protocol, which I think is not a bad idea. Remember that NMBAs do not provide analgesia, sedation, or amnesia. They just paralyze you, okay? So it is not good to be giving paralytics without sedation. And sometimes when you do interfacility transfers, one of the first things you're gonna want to make sure of if they're on a vent and not moving is, when was the last time they got some sedation? Because we still have, I remember being at Abbott on SCT, having SCT transfers where it's like they get there, heart rate's 130, there's tears coming out of their eyes, and the patient's completely still. They say, yeah, he's completely good and sedated. He's not moving at all. It's been great. He got rocuronium or vecuronium, last an hour. When was the last time he got any sedation? An hour ago when we gave him the etomidate. They've got nothing since. Nope, they haven't moved. They're perfectly fine. Yeah, one person actually said, we sedated them with more rock. Oh, no. Yeah, it was not good. So anyway, make sure that you make sure that you know when the last dose of sedation was, and make sure that you get sedation on board, especially if the monitors are telling you that maybe they're not sedated, because there's no analgesia, no sedation, no amnesia. They remember the whole terrible thing. All right. So now we're going to move into the section on specifically on the neuromuscular blockade agents pharmacology. Chief, this was slide 308. Did you want to take over? No? Are you sure? Okay. So remember, there's only one depolarizer, sucks. Everything else is a non-depolarizer. So instead of memorizing the non-depolarizers, just know that the one depolarizer sucks. Everything else is not. So it occupies the acetylcholine receptor, depolarizes it. That's why you see the defasciculations. It pretends that it's acetylcholine. It fits the receptor perfectly like it, but it's really lying. It doesn't cause the contraction, it just paralyzes that muscle, but it does depolarize it at the end plate just a little bit. Remember choline and choline, succinylcholine, acetylcholine, it's the acetylcholine agonist. What happens is the depolarization activity of succinylcholine on the acetylcholine receptor basically just pounds that continuously, triggering this action potential, which rapidly depolarizes this muscle. It makes it refractory to any further stimulation, and it makes it, this continuous depolarization can also cause a sustained contraction, which makes that twitching, that fasciculation that you see. Have you ever seen that before? Underneath their neck, when you push it, it looks like little bags of worms underneath the skin as it's depolarizing and going down. It's really freaky looking. Sometimes they'll even twitch a little bit. You get muscular twitching like it says there, and it's, but you know that that's good because that's working. It's now making it unusable. It's preventing any further stimulation. They go flaccid really quickly after that. The non-competitive nature of SUX means that if you increase the concentration of acetylcholine, it will not affect its efficacy. In other words, it binds very strongly to it. It mimics it exactly, and it's not reversible. There's no antidote for it, so to speak. You often hear about not giving SUX to burn patients. That's kind of a misnomer in that if you pull someone out of a burning building and they get to your ambulance or they come to my emergency department and you need to put them down, it is not that it's contraindicated because it's acute. You just pulled them out of the house fire. It just happened. They haven't had time to necessarily develop hyperkalemia, for example. But if you know that they have, what's different, however, is if this patient just got brought from the scene of a crush injury, for example, or a tornado or a house collapse on, they've been trapped for a couple hours. These are considerations where if you think they may have rhabdo, if you think they may be hyperkalemic already, if you think that that's an issue, you want to be careful about using a depolarizing drug. The other thing is if you're doing, say, an interfacility transfer, and it's a burn patient, they're now going to Mercy for the burn center, but this happened more than 72 hours ago. Now, there is a chance that they're hyperkalemic, that burn. So not 70 minutes ago, but 72 hours ago for a burn. Then you don't want to give it. The other one is a known history of muscular dystrophy. Muscular dystrophy is a motor muscular problem where theoretically the depolarization of succinylcholine can trigger hyperkalemia in somebody who has muscular dystrophy. So that's when you don't want to use it either. Okay. It's very rapid. It causes that initial continuous muscle contraction that wears out the receptor. Again, that's what the pounding is for, just keeps wearing it out until it's no longer usable, eventually causing paralysis.
So there's no contraindications for any other paralytic for someone with MD?
Right, that's when you would use a non-depolarizer. Yep. The side effects, like the fasciculations, are actually useful to know that it's working. But other things you can get, some patients, not many, but some patients have woken up from their anesthesia saying, my muscles hurt terribly. They get really bad myalgias. Well, that's because the receptor was getting pounded, causing contractions at first before it caused paralysis, and they're just sore. Okay. Adverse conditions, induced hyperkalemia or malignant hyperthermia. We talked about the hyperkalemia, but malignant hyperthermia, I'll talk about this first. So the depolarizing, remember we said causes that continuous stimulation and firing over time that can cause muscle cells to break down. When that happens, remember potassium is the major cation intracellularly. So if that does break down some cells, where is it going to spill? Into the bloodstream. And so this is the theoretical concern of causing some hyperkalemia. It might change it by like 0.2 to 0.5 milliequivalent per liter, which is not a problem if you're not already hyperkalemic. But if you are already hyperkalemic, it might be a problem depending on where you start. So again, we remembered about 24 hours after some kind of injury, especially burns after 72 hours, just use a non-depolarizing drug. Anyone heard of malignant hyperthermia before? Malignant hyperthermia can be triggered by succinylcholine. Mostly going to be male, although it can occur in females, it's mostly in males. What happens is it basically makes the body kind of short circuit and they go into overdrive and their end-tidal CO2 suddenly starts going through the roof, and they also suddenly get very hot. They can get febrile up to 104 to 106 degrees or more even. They get extreme muscle rigidity, masseter spasms. They get acidotic hyperkalemic. It can happen very quickly and be life-threatening. You have to recognize it immediately because you have to intervene immediately. Either stop giving it, or if they have a volatile anesthetic, stop it. And this really applies more to the anesthesiologist who's doing it. We're not going to be doing inhalational anesthetics. But what you're going to want to do is help the body get rid of the CO2 by increasing their minute ventilation, maximize oxygenation, fluids, and then pack them in ice. You got to bring their temperature down as fast as you can. You can consider a bicarb drip for the acidosis, maybe calcium chloride for stabilizing the cardiac membrane if you are worried about hyperkalemia. The antidote is a drug called dantrolene, which is a skeletal muscle relaxant, which kind of slows down or cools down the metabolic reaction and tries to restore order. There is a new drug called Ranadex. I actually have never seen it in the hospital, but it's apparently a newer version of dantrolene, a similar dose, same dose. But the point is you're trying to slow down, cool down this overdrive metabolically. So can you explain why the end-tidal CO2 is a great warning sign for you? If you're halfway through a 2-hour transport for whatever reason, this trauma patient, they got sucks and all of a sudden their CO2 becomes 80. Why would it go up to 80? Can you explain that? What did we just get through saying is the primary problem in malignant hyperthermia? It causes cellular metabolism. Underdrive or overdrive? Overdrive. So the engine is revving faster, right?
Doing a bunch of anabolic or anaerobic.
Yeah, there may be some of that going on for sure, which is why you want to improve oxygenation and give fluids and everything. But when you rev up your engine on your car, does more waste come out the tailpipe or less? A lot more, right? Yeah, yeah, so your cellular metabolism is now in overdrive and you're revving it up. You get hyperthermic, you get febrile. What happens when you get febrile? You're also increasing your cellular metabolic rate. And when you do that, your cells are revving up its engines. It's creating more waste, which then ends up in the lungs as it's breathing out, and now your end tidal is going through the roof. So that's why that's one of the earliest things. That's one of the things that the anesthesiologist will keep an eye on in the operating room at all times. Because they should be nice and, 35 to 45, right at 40, then all of a sudden it just goes, then that anesthesiologist is going to stand up quick and figure out what's going on. Because if that's what's going on, then they're going to try to do all these other things, pack them on ice, oxygenation, hyperventilate them, get their CO2 under control. Okay, let's see if this will play. It should play.
I think we have the we cracked her out, see how it looks. Symmetrical?
Yeah, I think they look great.
All right, let's start closing. Can I get a suture, please? Thank you.
Doctor, I think we have a problem. What is it? I think the patient's developing malignant hyperthermia. Her heart rate and blood pressure have dramatically increased despite me giving more anesthesia. More importantly, her end-tidal CO2 is very increased despite me giving ventilation, and her temperature has increased by about a degree to a degree and a half in the last 2 minutes.
What do you need for me to do?
So I'm going to need you to go ahead and close.
All right, we're there.
Okay.
Can you
Jen,
get the stapler, please?
can you go ahead and get the MH card and call for help, please?
Sure.
Thank you.
So it'll increase that quick?
Yeah, it's really pretty dramatic how fast it can happen. So sorry, every time I start a video, I have to start over again. But what actually started happening first? The heart rate started going up first, and that might be one of your first indications that there's a problem. Do you notice what he said? He said, in spite of.
He tried interventions for all the
Right,
different things.
and common things being common, especially towards the end of anesthesia, because what anesthesiologists like to do is try to start guessing when the surgeon says, I'm closing, they start to guess about how long it's going to take, and they start turning the anesthesia down. Because ideally, they don't want to be stuck there. Like what they don't want to happen is the surgeon is completely done, the surgery's over. But the patient is now, they didn't start waking up the patient until the last stitch is being made. Well, that's not necessary because they could have started 10 minutes prior, slowly waking them up so that by the time they wake up, boom, the procedure is done and they don't have to waste time in the OR because they get behind schedule, right? And anesthesia's got a tea time at 2 o'clock on the golf course. I mean, they got to hurry up. So what they do is they try to turn the anesthesia down while they're closing, not at the end of closure. So not so the patient feels it or anything, but so that as the patient starts to care, the procedure is done. And now the patient wakes up in 5 minutes instead of 20, and they can move to recovery and be done, right? Well, sometimes if they don't time it right, the patient will start to feel the pain or start to wake up before it's completely done and their heart rate starts to go up. So he did all these things. He said, I gave some extra anesthesia, and in spite of all my efforts, end tidal's going up, temperature's going up, heart rate's going up. I think this is malignant hyperthermia, especially with the temperature rising at the same time. Because usually that doesn't happen because they're waking up too soon. But the increased heart rate does, for sure. And even the end tidal CO2 going up a little bit can be a result of that too, but not from 50 to 65. That's a lot. Okay, so, but yeah, it does happen very fast like that. All right, home stretch, non-depolarizing. Non-depolarizing NMBAs like ROC, these are competitive neuromuscular blockades. It does not bind the receptor nearly as strong. It is a little bit more weak. It doesn't initiate a depolarization at the motor end plate like SUX does, which is why you don't see the bag of worms under the skin. You don't see the defasciculations, okay? Instead, it just blocks activation of the muscle. And at large dose, as a result, large doses of acetylcholine and acetylcholine creating drugs can displace ROC from the receptor and reverse the paralysis. So there's two ways to do that. There's one, acetylcholinesterases, like neostigmine. What's an acetylcholinesterase? What is ACE? Anything that ends in ASE, an ACE, what is that usually? It's an enzyme. So acetylcholinesterase is an enzyme that regenerates acetylcholine. It, in other words, makes more acetylcholine available by regenerating it faster. So how would that be a reversal for rocuronium? What did we just say? It's weakly bound, right? And it's competitive, meaning it can be booted off with enough overpowering. And so an acetylcholinesterase, an enzyme like neostigmine, that a drug like neostigmine that regenerates acetylcholinesterase and therefore makes more neurotransmitter available, can kick off the rocuronium. Now, there are selective reversal agents like SCCAD, which actually selectively binds and kicks off the rocuronium from the receptors. It doesn't work from making it overpowered with more acetylcholine like neostigmine, it just kicks it off. SCCAD is a relatively new medication that helps reverse rocuronium if needed. Rocuronium has a very fast onset, but only at intubating doses. In other words, if you gave rock at low doses, it will work, but it will take a few minutes and not nearly as fast. At our doses of 60, 80, 100 milligrams, it does work almost as fast as sucks. Okay. It lasts quite a bit longer than succinylcholine, 30 to 45 minutes compared to 5 minutes for sucks. Okay. Because it prevents any further depolarization, there will not be an action potential and no muscle movement will be allowed. And the good news is, because it's not a depolarizer, it doesn't contribute to hyperkalemia or malignant hyperthermia. So, rock can be redosed if needed. You can also pre-treat the fasciculations that might occur from sucks. To pre-treat, you would use a 1/10 the dose. You've seen that twice now, so that might be a test question. So now, do you understand the mechanism of action of pre-treating if you are worried about the defasciculations from a depolarizing drug like sucks? You give a 1/10 of a dose of rock, just a very little dose, so that it binds a bunch of those receptors already, so that succinylcholine doesn't have as many to bind, so it doesn't cause as bad of fasciculations. That's why they call it a defasciculating dose. Okay, makes sense? If you need longer paralysis, this is great because it lasts longer than sucks. Can be used for RSI. You should also know that all these mechanisms of actions, etc. And again, notice the push dose for induction is in milligrams, but the infusion dose for maintenance is in micrograms. Okay. That's why it's only in the milligram doses when you're giving it for RSI that it acts like a depolarizing drug, speed-wise. As we've discussed, there are some reversal agents only for the non-depolarizing. We mentioned neostigmine, we mentioned SCCAD. Just be able to recognize those two as reversal agents for non-depolarizing NMBAs. Anything in particular, Chief, for the exam?
No, the mechanism. So neostigmine, just like Dr. Tan said, it inundates the junction with acetylcholine. So just like carbon monoxide kicks off oxygen off hemoglobin, so SCCAD, like Dr. Tan said, binds it. It binds it, render it inert. So know how each of them work differently.
Yep.
Is there a reason you give someone an infusion dose of rock, or like put them on an infusion of rock? Like, is that?
Oh yeah, there's a lot of reasons.
Yeah. Yeah, if you need to keep them from moving in the ICU for whatever reason.
Well, we'll learn more about that event.
Yeah.
Because we're going to ventilate, we're going to paralyze asthmatics. We're going to paralyze people who have a high respiratory rate on our AAC clinician event. We're going to paralyze your blood. Because I'm not going to deal with that. So we're going to get you dialed in by paralyzing you first.
And when they do have paralytic drips in the ICU, they're very, very, very diligent about chasing it concurrently with a sedative drip. They maintain very close eye on that because the patient can't talk or move or say I'm in pain or point or anything. So they're very good about maintaining good sedation as well on top of the paralytic. But yeah, there are some times where no matter how much sedation you give them, they cannot synchronize to the vent for whatever reason. Maybe they're on a high frequency oscillator. Just there's a number of reasons. You'll get that when you do your vent classes, but yeah, those are some reasons why. So the mechanism of neostigmine, as we mentioned already, overwhelming that synectic cleft with acetylcholine to drive it off, rocuronium off. Sugamidex encapsulates the rocuronium, binds it, makes it useless, and it's available to reverse any blockade. Really, it's the new gold standard of non-depolarizing reversal instead of neostigmine. Sugamidex has taken over as the primary drug. So comparing the two, this is a very, very good table to know, simply because in one single table you can compare and contrast the two, making it really good fodder for test questions and stuff. Vecuronium is simply another one of these non-depolarizing drugs. It takes a little bit longer for onset because it also lasts longer. So remember, they're typically directly related. The longer it lasts, the longer it takes to be onset as well. So that can last up to an hour, maybe even a little bit more. But it's a non-depolarizer, just like rock. It's not used for RSI, but it is used in the ICU for someone who just needs to prolonged paralysis. The other nice thing about VEC is that it has to be reconstituted in powder form. I believe VEC is the one that's powder, which means shelf life is way better. It's a powder. So once you reconstitute it, then the clock starts ticking, right? But whereas all the others are liquid, SUX has to be refrigerated, and that is a logistical issue for a lot of EMS agencies. So VEC is one of those things where some EMS services like it because it's a lot easier to maintain, transport, keep for longer periods of time. Nimbex or cisatracurium is also long duration. Usually it's if they need continuous paralysis by infusion. I don't think I've ever seen it used as like in induction. There's its loading and infusion doses. Because unlike a lot of other drugs, which requires metabolism hepatically or renally, this is metabolized in the blood plasma. So a lot of ICU patients have renal failure or shock liver or other things making hepatically cleared or renally cleared drugs a problem. And if they need longer sedation and paralysis, then Nimbex is great because it's metabolized in the plasma. It doesn't need the liver or the kidney. So that's one of the unique things about this one. And again, whenever you find a drug with a unique property, you should probably know that unique property. There's other ones that you can read on your textbook, page 327, pancuronium, atracurium. Your homework assignment for the next 6 days, yes, including tomorrow, July 4th, whether you like it or not.
No, take it off.
Review the chapters listed in your syllabus. Write a summation of what's the Preox article?
So I handed out that Richard Levitan article on Preox,
Oh,
the study.
okay. Oh, nice, okay.
So a part of critical care medicine, guys, even as a paramedic, is to know the journals and look at the articles that are coming out for evidence-based medicine. In emergency medicine, we don't see that a whole lot in the paramedic field, but in the critical care field, they're doing studies all the time, right? And so this is one of these studies that is a landmark study on pre-oxygenation of a patient and intubation. So please take the time to read through it and give me 100-word summation on the pearls or what you've learned from that study and how maybe you can apply it to your practice, or I'll leave it up to you, but just put 100 words on what you've learned from it and how you can use it in your practice, basically.
You want us to bring it to you next week, or do you want to?
It's homework to do next week.
Like, turn it in paper form or
Yep.
email?
Type it, no, type it up and turn it in.
Cool.
Yeah.
So single
Next
space,
week.
double space, I don't care, just write it.
100 words.
Yeah, I should know if you wanted it, then email.
Nope, just it's homework, so type it up and bring it in. Make
And
sure-
it's just a summary. So it's not 1,000 words, it's 100.
Yeah, I mean, really, you could do more. And you won't get extra points if you do more, just minimum 100.
I have a printer.
You can email it to me and I can print it to you. If you don't have a printer, email it to me.
Maybe library.
Also, be sure you study your RSI and DSI handouts. Compare and contrast them. That's going to be important. Remember, we are absolutely committed to your success. So remember, we've got study hall coming up. Anytime you need extra help for anything, let us know if you need it. That's our contact information. Also, if any of you are interested, that cadaver lab I mentioned, the registration is open. It is August 19th is the deadline for registration.
It's awesome.
August 21 or 22. You don't do both days, you just do one or the other. It's the same thing 2 days to try to catch people on shifts.
I went maybe 3 years ago, and it was amazing.
Glad you had fun. Glad you had fun. All right. All right. Any additional questions or comments, concerns? I know we covered a lot of material. This was a packed day for sure. But hopefully, what we have tried to do is take this information and compartmentalize it and categorize it as much as possible to break it down into its component parts to make it as easy as possible for you, and therefore make it easier to study and apply. So,
Yeah, next week is a mental break. In the afternoon, we'll have skill stations.
yeah. And next week, we're only having didactics up until lunchtime, and after lunchtime, it's hands-on. It's the lab. Basically, it's preparing you for your July 25.